name is Maria Abreu. I'm at the University of Miami, and we're delighted to have you. We're delighted to see so many bright faces. I was talking to my colleagues and sharing with them that I'm really delighted that we have so many of our nurse colleagues here with us, because as we all know, you're the ones that keep the patients alive, and so it's very important to educate you. So we're lucky that we have one of these GALA conferences here in South Florida, even though, are all of you from South Florida? Are some of you out-of-towners, besides the speakers? Out-of-towners? Awesome. Welcome. I think the weather will be a little bit better today. In addition to my day job, I'm Mrs. Paul Martin by night. Married him for his looks, charming personality. But I advise people to marry for money whenever I can. So you can see that there's a predilection for having these in warm places, and these are GALA past conferences. As far as I can tell, Lisa Petticone always hits it out of the park. What I love about this meeting is, I would say to you, it's sort of a curated version of what's hot in GI, right? It's not necessarily meant to be like a board review or something like that, but just a curated thing of what's novel. And you're at this one, so you know you're at this one. And it was started by the GI and Liver Association with the Texas Liver Institute with Fred Poordat at the helm. We're very grateful. We really couldn't put this on and offer such a deep discount on credits if it weren't for our sponsors, AbbVie and Shionogi, as our lead sponsors, Intercept Pharmaceuticals. I learned so much actually from going around to the exhibits yesterday of stuff I didn't know. And you can see the gold level sponsors and the exhibitors. It's through their grants that we're able to put this on for you, and we hope that you'll visit the exhibits whenever possible. Some of you, I saw that the room was pretty full for the breakfast session this morning. There's also a lunch session that will take place that will be presented by Bruce Bacon. Hopefully you'll join us for that. I'll highlight that on the back of your badges there is a, the breakout session, the parallel session that you've been assigned to, and all of these are going to be, the real joy of this is that they will be very interactive and an opportunity to ask questions and have it be a whole lot less formal. This is the information about CME credits and MOC credits, so it's great that we not only offer CME, but we also offer MOCs for the physicians. Okay, all of that for the CME, our sponsors for supporting the CME activity, so thank you to those sponsors. And the educational objectives, I won't read them. Disclosures, I won't read them. But the CME is being provided by Annenberg Center, so very much on the up and up. Oops, did I do that? Okay. So it's my pleasure to introduce Dr. Joel Richter, who's the Chief of Gastroenterology at the University of South Florida, a neighbor now, which is wonderful for us. As you know, Dr. Richter has contributed really immensely to the field of esophagology in ways, in every dimension. He really defined this field, and so we're very blessed and lucky to have him. Thank you, Joel, for coming.
Maria, thank you. I think after 8 years, I'm as close to a native Floridian as most of the patients I take care of, at least, and in Tampa. It's always good to be together with this group. Many of you, we see each other at the Florida GI Society. So as the others have done, we'll have presentations, and we'll have plenty of times for questions and answers afterwards. And please do feel free to send up cards. Maria, are we doing it with cards this time, or are they going to do the microphone? Okay. Well, whatever it is, we'll try to make sure everybody's comfortable. So I'm going to talk about the treatment of the non-achalasia motor disorders, emphasize esophagogastric junction outflow obstruction, diffuse esophageal spasm, and the jackhammer esophagus. So no interests or relationships are disclosed. So we will talk about medical treatments, endoscopic and surgical management, particularly POEMs. We'll talk about the hypermotility disorders, and I'm going to center some of this around cases that I've had over the last couple of years at the University of South Florida Swallowing Center. All right, this is with the advent of high-resolution manometry. Before we had high-resolution manometry, we did not identify this entity. Maybe we would say this patient's sphincter didn't relax well, but they had normal peristalsis, but we did not have a description for this. This is truly the new diagnosis and important diagnosis seen with high-resolution manometry. Esophagogastric junction outflow obstruction. And the important thing to notice on these patients is that they invariably have some degree of normal peristalsis. If they didn't have peristalsis, then it would obviously be achalasia. But they've got normal peristalsis, and they've got obstruction at the esophagogastric junction that doesn't open up adequately, as shown by an IRP, in this case being 20 millimeters of mercury, or by definition greater than 15 millimeters of mercury. And in that little area that you see of the green, that's the intrabolus pressure. That's the esophagus kind of squeezing that compartment as it's trying to push things through. Now, this is turning out in our lab to be second to achalasia as the most frequent major motility disturbance that we identify. This is a paper Steve Clayton and I did several years ago, and it gives you a good generic idea of what these patients are like. We had 49 patients with outflow obstruction. At that point in time, it was about 4% of our motility disturbances. They do tend to be a little bit more women. Their average age is around 60. And they can have a number of symptoms, but the ones you need to pay attention to are the ones associated with dysphagia and regurgitation. Those are the ones that your treatment are going to be most effective. And not only do you have to use your manometry skills to make this diagnosis, but you also have to use other tests, because there's two forms of outflow obstructions. There's the anatomic variety, and in some series that's up to half of these patients. And the most common anatomic abnormalities are esophageal stricture, large hiatal hernias, but you also see others like eosinophilic esophagitis, lap bands that have slipped, tightness in fundoplications, varices, and occasionally, and you have to look for this, particularly in patients that are having significant weight loss, this can be a presentation of esophageal cancer. And then about the other half of these patients have a functional abnormality. For whatever reason, the LES doesn't work, and some people have actually alluded to this as being type 4 achalasia if you use a classic 1, 2, 3, and 4. Major symptoms are dysphagia and regurgitation, and unfortunately, neither high-resolution manometry or the time-barium esophagram in and of itself sorts these out, though the x-rays can be very helpful, as I'll show you in a moment, for attempting to identify what's going on. Now, here's a patient presenting with what turns out to be mechanical outflow obstruction. Actually, she was being evaluated for an anti-reflux operation, and at the time of the evaluation, manometry was done. They found this normal peristalsis, but they saw that the lower esophageal sphincter did not relax. Her LES pressure was 68. Her residual pressure was 48, but you can see nice, normal, healthy peristalsis. And then when we got the time-barium esophagram, if you look just at the white barium, you can obviously see that it is kind of deviated around this bulge. And that white bulge, that shadow that you're seeing in the middle, that's actually 2/3 of the patient's stomach up in the chest, interfering with the esophagus emptying, and this is the reason she had her outflow obstruction. And then to confirm that, you can see the pill nicely hang up. Absolutely no contraindication to anti-reflux surgery. She did well and has gone on her merry way. Another gentleman, interestingly, his driving symptom in this situation was regurgitation. He had some dysphagia, he had regurgitation, and I was actually surprised with his manometry study showing good, healthy peristalsis. His LES pressure was 27. His residual pressure was 22. This is his time-barium swallow. If anything, his time-barium swallow looks like achalasia. You've got the dilatation of the esophagus at the very bottom. You have the bird's beak. We didn't find anything else going on. I treated this gentleman with pneumatic dilatation. He actually lives in the Naples area, and he's now out about 6 years with a single pneumatic dilatation. So how do you approach this? We're still evolving our concepts about this. Steve Clayton and I had this article in the Red Journal in the last couple of months to kind of put our thoughts together, but I think many in the area are also thinking the same way. High-resolution manometry can raise the question about the diagnosis, but there are false positives in this test, particularly associated with small hiatal hernias, and you can do a couple of other things maybe to bring it out by sitting the patient up or by giving them multiple swallows. Sometimes that'll help bring out whether or not this is a true obstruction. You need to evaluate these patients carefully with other tests to make sure it's not a mechanical disorder, and if that's the case, treat them appropriately. And then our group and the Chicago group both believe that you need to have a secondary test before you get particularly aggressive at treating the outflow obstruction. We use the simple time barium swallow, give the patient 200 cc's of barium to drink in the upright position, measure emptying at 1 in 5 minutes, give a pill to follow. It's a very accurate test of the compliance at the esophagogastric junction. The Chicago group is quite interested in this new flip technology that will also help you. And if both of those show obstruction, then we feel that's a firm diagnosis, and particularly if dysphagia and regurgitation are the driving symptoms, then we'll do more aggressive treatment. And as I'll show you, we have some very positive data with pneumatic dilatation. If it doesn't, if we can't find other parameters, then we'll do more safe, simple things to do, sometimes muscle relaxants, sometimes just simple esophageal dilatation. How do you treat these patients and what is the success rate? We don't know because all these are case series. As you can see, everybody has done everything on these patients, including no treatment. And I do believe no treatment is the appropriate thing if the patient is presenting with asthma or presenting with belching or presenting with very atypical symptoms not classically associated with obstruction. There, I'm not sure what to make with that outflow obstruction, and I wouldn't get too aggressive on it. People have tried muscle relaxant, bougie therapy, botulinum toxin. You can see Botox being a variant of achalasia. This is a simple and easy thing to do anywhere in the United States, pneumatic dilatation. And the few reports on surgery have all been very positive, and that shouldn't be surprising at all. So number one, make sure you've excluded a mechanical cause for their outflow obstruction. Again, that can be in about half of these patients. We initially had enthusiasm with Botox injections, and it did work, an average of 6 months to a year. But actually, over the first year or so that we were doing that, we had 2 patients come back. And they came back, and they were having not only the obstruction for solids, but now they were beginning to have liquid problems and regurgitation, and both of those had evolved to a type 2 or type 3 spastic achalasia. So more recently, we've been doing pneumatic dilatation on these patients, and actually over the 4 years we've been doing pneumatic dilatation, we've had no patient evolve to achalasia. And this is actually one of these patients on the your left, the classic pattern of a peristaltic way with outflow obstruction, and then about a year later, a type 3 achalasia. You do have to be a little careful in today's environment with injections of Botox, particularly if you think myotomy is going to be your treatment of this patient. Multiple Botox injections will interfere in the ability to do myotomies. It makes the planes of dissections a little bit more difficult, particularly they say in the POEMS literature. On the other hand, I don't think it precludes using the Botox to help you make a diagnosis or maybe a single injection. But if you think you want something more definitive in the patient, Botox will make the surgery more difficult. And then the other thing we're noticing about, and this has to do with using these needles now that are being developed for EMR and ESD and other things, these longer needles. Be careful about using those to do your Botox injections because they can pierce through the esophagus. There have been reported cases of mediastinitis, pseudoaneurysms, and actually 3 deaths. So when you're using Botox, make sure you use that shorter needle that we've traditionally been using for this problem. This is our experience with pneumatic dilatation in 33 patients. You can see on the bottom side, looking at the treatment, and then follow up at 3 months, and subsequently, as I've alluded to, some of these patients have been followed up to 5 years. Initially on, we had a good response in 22 of our 33 patients. Also, 6 required another treatment, so overall, we've had an excellent response in about 85%. Again, this is a case series, but we think it does mean something, because if you look at the top line that's underlined in red, the time barium swallow at the start of these patients showed a retention column of about 11 centimeters. And at the end of treatment, it was down to basically the median number was 0. And also the tablet didn't pass initially in 76% of the patients, and after treatment and follow-up, it was only retained in 40%. So for those of you all that are comfortable with pneumatic dilatation, you should be more comfortable with it because it is an important tool in taking care of patients with not only EGU but also achalasia. This really, in my otherwise healthy patient, is my first-line therapy. And here's a nice example of a patient, a 42-year-old lady, presenting with dysphagia, excuse me, and in this case, chest pain. LES pressure was 76, her residual pressure was 26. You can see she had 100% bolus clearance. We did a single pneumatic dilatation, she came back, and look how powerful that stretching is for taking out the high LES pressure. Her LES pressure was down to 26, her residual pressure was down to 8, and again, she's done quite well for an extended period of time. Another thing you have to be aware about, and I say be aware about it because the reality of it is we can't do much to change it, but there is no question that narcotics do affect sphincter relaxation. It affects kappa receptors, it can impair the relaxation, and seems to be potentially a problem more likely seen in outflow obstruction and in the spastic type 3 achalasia. Having said that, the reality is trying to get these patients off of narcotics is not very realistic. So basically, we treat these patients like we would any of these, and at least we had an abstract at last year's ACG showing that it really didn't make any difference. Well, now let's switch to spasms, not as common, but the motility studies are certainly a lot more striking. This is the hypercontracting esophagus, what we used to call in the old days when I was working with Don Costell as a young resident and fellow. This is the nutcracker esophagus. Now today, we use different definitions to define it. We use what we call the distal contractile integral. That's a measure of the volume and strength of the activity in the distal esophagus. Normal is about 500. We used to say 5,000. Now that we've got larger groups of normal up to 8,000. So if you've got contractions that are averaging greater than 8,000, that could be a hypercontracting esophagus. But the Chicago group has confused us because they also have put in their own colorful name that I'll mention in a moment. This is diffuse esophageal spasm. And in this case, if there's more than 20% of your contractions are associated with a simultaneous activity, or what they like to call in the Chicago classification, premature contractions, then that's diffuse esophageal spasm. It is not type 3 achalasia in this case because the lower esophageal sphincter is relaxing. And then the Chicago's version of the nutcracker esophagus is the jackhammer esophagus. And you can see why they use this. These are really super contracting esophagi, oftentimes associated with chest pain. And in this case, the DCI was about 16,000. So how do you treat these? And this is about the same story as we've always had in the spastic disorders and in the non-cardiac chest pain. It is difficult because with dysphagia, we understand what causes dysphagia. particularly the esophagogastric junction, is so important in dysphagia. But in chest pain, so many things can contribute to it, whether or not it's the spasm, whether or not it's the associated reflux, or whether or not it's the esophageal distension. And therefore, we don't have a single one treatment that will fix all of these possible etiologies. Now, we've tried a number of things, few controlled studies. In the day, we tried nitrates, anticholinergics, hydralazine, calcium antagonist. And if you do meta-analyses on any of these, they show no efficacy. Psychotropic drugs have been not well studied and not frequently studied, but in the two studies, one with trazodone and one with imipramine, they did show improvement of the patient's symptoms as compared to the placebo, but the motility activity in the esophagus kept on chugging along. So it's working centrally and not peripherally. But I think now we do have medical therapy that can help these patients, and we can also use it, I think, as a diagnostic test as we maybe want to go long-term to something maybe more aggressive but more permanent, relieving these symptoms. And that's, again, like we did with achalasia, using botulinum toxin in these non-achalasia motor disorders. Here's a study out of the Netherlands, 22 patients with DES, or the nutcracker esophagus. Here they did injections at the esophagogastric junction or around it, and then up into the spastic areas of the distal esophagus. You can see the nice improvement of symptoms, but particularly the nice improvement of the dysphagia as compared to the sham. And then this is an important slide done by another group. This is a study done with a group out of France, 45 patients, all with dysphagia. About half of them had chest pain, same type of scenario. And I circled or put in a box the patients with achalasia and a low IRP. They did not do well. But all the other groups, achalasia with a high IRP, jackhammer, DES, outflow obstruction, nutcracker, 2/3 to 3/4 by 3 months or 2 months had good symptom relief, and it continued on in about half of the patients. So Botox can be very nice to help make the diagnosis and confirm the symptoms, and in some patients this may be permanent treatment for them. Here's probably one of the most striking cases that I have seen over the years, particularly because the big issue in this patient, which is much more problematic, was the chest pain. This was an individual from the Lakeland area who was a healthy 45, 50-year-old gentleman working in the restaurant business, delivering seafood to a lot of restaurants in several county areas, developed this chest pain syndrome. They ruled out cardiac, came to see us, and as you can see, he had a super jackhammer esophagus, and this is kind of the composite of his 10 swallows. His basal LES pressure was 13. His IRP was actually normal at 9.5, but supercontracting esophagus, did 200 units of Botox to him, and even I was amazed by this response. Totally converted him to normal, LES pressure 17, 80% normal peristalsis, chest pain went away, and he didn't come back. I want to be cautious about this. This is chest pain. We'll come back to something else that wasn't as successful. Chest pain's more problematic, but when it occurs and you help them, it is quite dramatic. Now here's somebody with a combination of outflow obstruction and a jackhammer esophagus. Here the LES pressure was 27, the IRP was 22. That esophagus is just squeezing very hard to push things through. You can see the DCI there is 34,000. 65-year-old gentleman, primary symptom in this case, dysphagia. I actually did pneumatic dilatation on him, did it at the lower esophagus and also up into the body of the esophagus, came back 3 months later, a dramatic response. He did well for 3 years, and then when his symptoms came back, I actually sent him for POEMS surgery. Now here's another lady. This is a lady sent to me by one of my former fellows in Birmingham, Alabama. And Dr. Champion says, this is a nice lady that's having this excruciating chest pain. She has this motor disorder, and we really are not successful. Could she come down to Florida to see you? And I said, certainly. So she had chest pain, cough, voice changes, and didn't have any dysphagia. And actually, the first trip she came by herself. We did her manometry. Actually, over the left is a copy of the tracing that was done in Birmingham. Over on the right is a tracing that we did. And my motility nurse, Betsy, was quite, she says, Dr. Richter, she's having chest pain during the study. And I came in and looked at the study, and I compared it to the one Dr. Champion did 2 months ago when she wasn't having chest pain. And you can see there's really not any difference. It's hypercontracting, but nothing particularly unusual about it. So we talked about the therapy. I decided to do Botox on her, let her go home, and then she came back to see me. And as what I like to do on these difficult to manage patients, I do high resolution manometry and time barium swallow, and then I visit with the patient. And here we have a high resolution manometry. I've done my job. That really looks quite a bit better. That lower esophageal sphincter is opening. Patient's chest pain was no better. This time she came with her daughter. She had lost her husband 1.5 years ago, become a social isolate, and really this was more depression than it was anything else. So be careful about the chest pain. That can be not quite as straightforward as the dysphagia, but the Botox can be a very helpful tool to help sort it out. Surgical myotomies. In the day when I was younger and my hair wasn't gray, and I probably have always had a beard almost, we would do surgeries on these patients, but it was difficult because you would have to do it through the chest, and it was quite unpredictable, and it was a large operation. A thoracotomy will ruin your life for a couple of months. So we did it, but we didn't do it with any enthusiasm. Now, with the advent of the recognition, the importance of type 3A achalasia to treat these patients differently, because again, as this time barium swallow shows you, they have multiple narrowing throughout the esophagus. It's just not at the esophagogastric junction. POEMS is more available now in the United States. There's at least 3 centers here in the state of Florida that are doing it. We're doing it. The University of Florida is doing it. And also they've begun a program in Orlando. So by skilled endoscopists or surgeons, this is something that we can offer. And this is actually a compilation of cases from throughout the United States published by the group from Baltimore, Johns Hopkins. We had some patients in here. But you can see in the patients with outflow obstruction and diffuse esophageal spasm and jackhammer that the success rate was 84 to 93% with variable follow-up, and resolution of their obstruction was done quite nicely. So in these patients with non-achalasia forms of esophageal motility disorders, outflow obstruction, DES, and jackhammer, I think we have a lot to offer these individuals today. Thank you very much. So we're going to move on now to talk about the impact of bariatric surgery on esophageal function and GERD. The speaker will be Dr. Mike Vasey. Mike is professor of medicine and otolaryngology at Vanderbilt. He is the clinical director of the division and also directs their swallowing center. Mike and I had the pleasure of working together probably for about 10 years. He's taught me a lot over the years, and he will continue to teach everybody here. Michael.
Good morning, everybody. Thank you, Joel. What Joel forgot to say is that he's my mentor, so he's taught me everything that I'm about to tell you. So thank you, Joel. There are different talks that we give on esophageal disorder, but this one we thought was interesting in that bariatric surgery is becoming more and more common, and we have a lot of patients that actually come to us and say, I have more reflux or I have trouble swallowing. So it'd be good to better understand the impact of the bariatric surgery and its various forms, and which one might increase the symptoms, which one might be better for it, so that way you know about it. Let's see if we can go forward. All right, these are my disclosures. Obesity. So what we do know is that obesity is a big problem in the US, and many of our patients have reflux symptoms. They get esophagitis, Barrett's esophagus, or adenocarcinoma. So obesity is associated with all of those. But what we tend not to discuss is actually that reflux symptoms and esophagitis start happening not when you get to the obesity stage, but when you just gain 10 pounds, so you become overweight. So just in that overweight area, that's where the degree of reflux starts going up, and it actually just plateaus at obesity. So can one reverse that process? If you are overweight and then you lose the 10 pounds or 15 pounds or 20 pounds, does that then mean that you may have less reflux? The answer is probably yes. We don't have good data. We do have anecdotal and case series, but the point being, overweight applies to this slide as well as obesity. So what is the mechanism through which reflux, either symptoms or the ones I mentioned, caused, should I say, by obesity? So increased intra-abdominal pressure, slower esophageal acid clearance, increased rate of hiatal hernia, and increased transient LES relaxation. All of those are sort of a vicious loop that patients get into, because the more reflux you have, the more likely you might be that you may get ineffective movement, and that just feeds into itself, and then you start getting reflux and esophagitis. So, what is the influence of bariatric surgery? Well, it impacts it in two ways. One, in reflux-type symptoms, but also in esophageal motility. So what are various bariatric surgery? We have the lap band shown on the left. You have the VBG on the right, upper Roux-en-Y gastric bypass, and sleeve gastrectomy on the right. What's important to realize about these, 3 of these are more restrictive procedures, while the other one is not, or at least a lot less. So lap band, VBG, and sleeve are restrictive procedures by definition. And I'll get to this when I show you the animal data, and I won't dwell on the animal data, but we should learn from it. These were done in the 1980s. Anytime you obstruct the esophagus or you create an obstructive pattern, either in the stomach or distal esophagus, that's going to impact esophageal motility. That will lead to dysphagia, which is really what's happening for many of our patients. So restrictive procedure, the top 3, are going to be more problematic when it comes to reflux, as well as dysphagia and dysmotility in the esophagus. Roux-en-Y is going to be the one you want if your patient has a lot of reflux and is obese and is trying to undergo some kind of bariatric surgery. So, gastric band and the esophagus. So we're doing less of these, but they were common. This results in weakening of the esophageal motility. Again, by definition, it's a restrictive procedure. Pouch dilation, worsening of reflux symptoms, esophageal dilation because of that restrictive nature, and echolalia-like symptoms. I'm going to show you a video of a patient that if I just showed you the video, didn't tell you anything about the patient, you'd say, oh, well, that's echolalia. And it could be, except the patient had a restrictive procedure. Now, sleeve gastrectomy, what happens? Let me see if this works. Yeah. So what happens with sleeve is you're essentially excluding major part of the stomach, and what you have is a stomach, you're tubularizing, that's a tough word, the stomach, and that is resulting in less compliance in the stomach, and that becomes a restrictive procedure. And by doing so, again, puts stress on the esophagus to squeeze more, if you will, and over time, it stops squeezing, so it becomes ineffective, and that leads to dysphagia on the side of patients. Now, sometimes patients come in and tell you what? Oh, I have regurgitation, I eat, stuff comes up. Well, this is by definition the function of many of these procedures, because when you restrict, things aren't going to go down, and the aim of many of these is to be restrictive so that patients don't eat as much so that they lose weight. But over time, as we all know, patient behavior, you tend to go back to your norm, and norm being, if you were overeating, then you're going to regurgitate, because now you have an anatomy that does not allow you to do so. So it's not that it's producing reflux in the context that we know about. In a patient that has reflux, that has intact stomach, you're thinking of a hiatal hernia, you're thinking of reflux of acid or bile, but that's a different phenomena in this group of patients, because these are restrictive. Anytime you put in any more than allowed, if you will, by that procedure, patients are going to regurgitate. Roux-en-Y. So remember, this is the one that if you have someone that's obese, and has reflux and is a candidate for any of these procedures, this is the one to do, and there are many studies. It is a malabsorptive process, but it does improve GERD. So this is the one to pick, and it has minimal effect on motility. So mechanism for GERD is decrease in LES, blunting of the angle of His, decreased gastric compliance, decreased gastric emptying, increasing in hernia, and esophageal dysmotility. You don't need to read any of this, just look at the arrows. This is a compilation of studies that suggest sleeve gastrectomy and reflux. I just wanted to point out that more of the studies suggest reflux's increase in sleeve and some that are actually decrease. But when you look closely, the ones that say decrease are symptom driven, while the ones that say increase are actually based on physiology such as pH monitoring and others. And this is a slide that actually was published in JAMA Surgery 2014, looking at GERD and sleeve gastrectomy and Roux-en-Y. And what you see is the change in symptoms of reflux. Red here is the gastric reflux with the gastric band, Roux-en-Y I mean. And you see that the number of people that got better post-Roux-en-Y was a lot more, while the number of patients that stayed the same or worsened was more with sleeve gastrectomy. So for reflux, it's felt that Roux-en-Y gastric bypass would be better operation. And there was a meta-analysis on this, and you see that clearly when you look at the odds ratio, about 9, and ranges anywhere from 5 to 17. So these odds ratio are pretty strong, suggesting that it does help reflux. If you have reflux and you're a candidate, this is the surgery to do. So, what about esophageal motility? Here's a case of a patient, 77-year-old male, presents with dysphagia to solids and liquids. Remember, when someone presents with dysphagia to solids, liquids, you're thinking dysmotility, you want to make sure it's not echolalia. Has regurgitation, aspiration pneumonia. Right now you're thinking echolalia. History of hernia repair 2 years ago. You go, well, okay, I'm not sure. Could this be echolalia? Weight loss of 6 pounds. Now, you do manometry. What does this manometry show? If you're not doing manometry, if you don't know about manometry, these are the isobars essentially. What it's showing is simultaneous contractions here. If you didn't know the history of the patient, when you looked at this, you would say, well, this looks almost like type 2 echolalia. So the patient's symptoms are classic. Manometry suggests possibly echolalia. And then video. So here's the first video. If you could start the first video. Dilated esophagus. Well, sounds still echolalia-like. And puckered G junction, that's echolalia. In fact, I have many patients referred saying, this patient has echolalia, can you do pneumatic dilation or help them? And then when you go through, there's gastric emptying problem. And when you do a retroflex view, you see a nice tight fundoplication. So, this is not really echolalia. It is echolalia. You can call it iatrogenic echolalia because it's really something we've done to the patient. You wrap that really tight and you let it sit. What's going to happen is esophagus is going to dilate. Patients are going to have dysphagia to solids, liquids. Manometry is going to look just like echolalia. So don't get confused by the idiopathic echolalia. This is really what we created. This is the second video, which we don't need right now. If you could stop that for now and let me go through the case first. Thank you. This is case number 2. This is a 65-year-old female that presents with dysphagia to solids and liquids. All right, then echolalia, associated regurgitation, sounds like echolalia, but history of lap band. The prior surgery had fundoplication. But really, it doesn't matter what they had. These are all restrictive procedures. Think about anytime you tie the esophagus or proximal stomach, esophagus is going to behave the same. So surgery and weight loss of 140 pounds. So now let's start the video, please. And what you see, anytime you see foam in the esophagus, it's dysmotility. This is dilated esophagus. Mucosal changes related to retention. Wide open GE junction. When you go through it, there's a secondary tight area, and that's the band. That's the patient, retroflex view will show you right there. So that's really, again, the impact of an obstructive procedure. All right, let's go to the slides now. And when you do, if you have Low resolution manometry, it shows like echolalia, simultaneous contraction, LES that doesn't relax, although that's not LES, it's the band. And then if you did high resolution, it would look like echolalia, but again, it isn't echolalia. So, what are the data regarding post-surgery? So this was interesting in that when you looked at echolalia or no echolalia cases, they called it echolalia, but remember, these are iatrogenic echolalia. This is clinically and manometrically and barium-wise, it looks like echolalia, but it's really predominantly due to operation. So fundoplication fundoplication and bariatric surgery can lead to a patient having echolalia-like symptom and physiologic findings. So here's a nice presentation. You have nice peristalsis. You have the lower esophageal sphincter. There is a swallow. LES relaxes. So this is where your LES is. What is this? Yeah, that's your band, right? So right in the proximal stomach, distal to the LES, the patient I showed you. So there's a secondary high pressure zone. It's not going to relax because it's a band. And this patient does not have echolalia, but it's a nice picture of a high resolution manometry and lap band. So esophageal post-lap band, you see that the rate of postoperatively, the rate of defective propagation increases. So what is that a function of? You put a band in, you leave it in long enough, it will fail. So that's what it's telling you. All right. Here's another one that essentially shows 69% of patients post-lap band had abnormal esophageal motility in 5 years. So these were studies. What's interesting is we don't learn from the past and we keep making the same mistakes over and over again, and this is really a function of that. So whoever came up with lap band or any of these restrictive procedures, they were thinking the right things. They were thinking, hey, how can I help this patient lose weight? But what they forgot is, well, what's the consequence of that on other parts of the body, i.e. esophagus? So here's an animal model I wanted to just share with you. This is an opossum model, and what they did was they essentially restricted. They put a band either in the stomach or the GE junction, and they watched what happened to the distal esophageal amplitude. This was control. In controls, nothing happened, but in those where they put it either in the distal esophagus or proximal stomach, amplitude reduced. When they let the band go, it went back to normal. The problem here is this was a very short-term study. So if you did that in humans, so you would put the lap band, you increase the pressure, then 2 weeks later let it go, yes, there will be an impact on the esophagus, then it will normalize. But what happens to our patients? It's left in place chronically. Once the video I showed you of a patient that has dilated esophagus, if you take that lap band out or you undo the fundoplication, that esophagus will not recover. It's too late for that esophagus. So this was a cat model. I didn't do this, by the way, if you guys love cats. I did not do this study. I had some cats, that's right. I loved my cats, all right. So I did not obstruct their distal esophagus. So what they did in this case was the same. They obstructed the distal esophagus. In this case, 40 millimeters of mercury was the cuff pressure, cuff being the cuff pressure of that obstruction. And what they saw is that, well, there's peristalsis. This is a barium swallow. And then there was an escape right about 4 centimeters above the LES. So there's an obstruction, peristalsis goes down, but then it hits that pressure zone and it now have regurgitation, if you will. The patients are regurgitating. What if you increase that cuff pressure? Well, that happens quicker, i.e. instead of 4 centimeters above the LES, it's happening at 6 centimeters. This was cuff pressure of 60 millimeters. And this is, again, a video of that same thing. So what happens then? As you increase the intragastric pressure, restrictive procedures, what happens is you're going to impact the peristalsis sequence of not only distal, but middle and proximal esophagus. And you already saw videos of this, so you see that this has been shown in the past. We knew this from many studies in the past. It's just being reproduced now in humans based on bariatric surgery. So again, intragastric pressure increases, distal and mid-esophageal contraction and peristaltic transit time increases. All right, so is it reversible? This is one study I showed you, very small sample size. The point being, I think time dependency is key on reversibility. If I put it in and a week later I let it down, yes, I didn't impact it. If I let it in and 5 years later, you're gonna have this motility without a doubt. In conclusion then, GERD is increased with sleeve gastrectomy but decreased in Roux-en-Y. Esophageal motility is altered after bariatric surgery, especially the restrictive procedures. Many patients have irreversible changes and lifelong struggle with dysphagia and regurgitation. And what do we do for this patient group that has dysphagia? All we can do is dilate intermittently, but I'm not sure that it's going to be effective in those that have already failed and the esophagus is dilated. Thank you so much.
So I think we're going to have plenty of time for questions and answers. You know, we'll have the microphones, and then we'll also, I think people are walking around with the cards to write out your questions, and I'll try to interpret them for the audience. Our next speaker is going to be talking about endoscopic therapy for GERD. Three of us have all had a Cleveland experience for a number of years. Ronnie is the most recent individual to move from Tucson, Arizona to Cleveland, Ohio, but has done a great job as professor of medicine at Case Western Reserve University and chief of GI at their Metro Hospital there in Cleveland. Ronnie.
Just to show you the difference between me and the other two speakers, they moved from Cleveland to hot weather. I moved from Tucson, Arizona, hot weather to Cleveland.
You'll move again, probably.
Okay, so this is my disclosures. So I'm going to talk about endoscopic therapy for gastroesophageal reflux disease. And when you talk about endoscopic therapy, there's a lot of history related to this area, as you all probably know. But when it comes to the utilization of these type of techniques, the first thing we need to look at is what does the physician get out of it? Why would physicians adopt these type of techniques in their clinical practice and offer it to patients? So first of all, physicians ask, is it efficacious? Does it work? Short-term, long-term? Do we have results that we can look at long-term and they're favorable? Is it safe? Very important to know. The other thing for many of us today, is it reimbursable? Is it difficult to get insurance companies to pay for these procedures? And does it have a role in my practice? Do I have the patient population that would be interested in such procedure? The next question, of course, is why would patients be interested in endoscopic therapy for gastroesophageal reflux disease? Well, this is one of them. This is the ever-growing number of potential side effects from chronic PPI treatment. And you probably all know about it because you hear it from your patients on a regular basis. Do I really need PPI long-term? Is it safe? And you can see here a long list of various complications from chronic PPI treatment. And as you all know, I mean, I'm not going to be surprised. I think in the last week I got 3 new publications that came out in relation to side effects from PPI, chronic PPI treatment. And as I always say, I think PPIs are responsible also for global warming and the hole in the ozone. Patients are exposed to all this information if you haven't even figured it out by now. When you just go kind of on websites, you will find anti-PPI websites. They're all over the place. For example, this one, Kiss Health Goodnight instead of Kiss Heartburn Goodnight. Or Heartburn suggesting the potential effect of PPIs on the heart. And not only that, there are also lawyers that are waiting out there, and they publish on all these websites that if you were using PPIs and develop any of these side effects, I'm not sure how they target patients that develop dementia on websites, but if you develop any of these side effects, then call us, because there's money to be made. So we can see where endoscopic therapy could be positioned and where a patient might be interested in this type of approach. Now, we all know that there's history when it comes to endoscopic therapy. They didn't start yesterday. In fact, they did not start even in the last decade. We know that the early ones came at the beginning of 2000. Many of them did not make it. And what was the reason for that? Why they initially failed? One, the procedures were time-consuming. It took a long time to perform them. The procedure required expertise. You had to have a certain number of procedures in order to know how to perform them, and then in order to maintain expertise, you had to perform a certain number of them every month, which many of the physicians could not keep up with. Adverse effects. There were a variety of adverse effects, some of them devastating to the patients. Objective clinical endpoints. Many of the studies demonstrated that when it came maybe to the short term, some of the objective clinical endpoints were met, but when it came to long term, they were not met. Lack of reimbursement. It was difficult to reimburse many of these procedures, and there were still available cheaper and more successful alternatives. So let's talk a little bit about what we currently have. When we look today at the procedures, endoscopic or surgical procedure, the new ones in particular, in relation to gastroesophageal reflux disease, they all fall under the category of what we call sphincter augmentation procedure. That's what they primarily do. They try to augment the effect of the sphincter, the lower esophageal sphincter. You can see the top four are all endoscopic procedures. The top two at the bottom two are surgical procedures, which I will not cover during this presentation. Now, the three most commonly used today, I would say, are the Strata procedure, the Muse, which is an abbreviation for Medigas Ultrasonic Surgical Endostapler, and Medigas is the name of the company. And then we have the TIF, or the Asofix. These are three different types of endoscopic techniques. And again, as I said, they're all sphincter augmentation endoscopic procedures. So how do they work? Well, the main effect of this procedure is truly to prevent reflux from occurring. They increase lower esophageal sphincter basal pressure. They decrease proximal migration of reflux, and that's very important because we know that this is a very important underlying mechanism for symptom generation. Reflux that reaches the upper part of the esophagus is more likely to be associated with symptom than reflux that reaches only the distal part of the esophagus. There's data to show that they decrease the rate of transient lower esophageal sphincter relaxations, and at least in relation to the Strata procedure, there is some data about alteration in esophageal sensitivity, potentially reducing esophageal sensation, and by that, improving symptom perception. Now, all of these procedures have almost the same study design, which I think was introduced primarily by the FDA. So if you wanted to get this procedure approved as a company, you had to meet those these objective and subjective clinical endpoints. So from a subjective clinical endpoints, you had to look at girth, health-related quality of life. You had to look at heartburn score and PPI use, and your ability to reduce it in patients that were already taking it or prevent patients from taking PPIs. From an objective point of view, the focus was on esophageal acid exposure. Most of the time it was the percent time the pH was less than 4, healing of erosive esophagitis, and looking at lower esophageal sphincter basal pressure before and after the procedure. Now, the target population was very specific. So not everybody could have those endoscopic intervention. So patients that were good candidates for this procedure or included in these studies were those that had to have an abnormal pH test if they had a normal endoscopy. They have to demonstrate an abnormal esophageal acid exposure. They could not have more than grade B erosive esophagitis. So grade C and D were not a good candidate for these procedures. They had to have a small hial hernia, less than 3 centimeters, as proposed in these studies. They had to demonstrate complete or partial response to PPI treatment. So complete lack of response to PPI treatment was a no-go for this type of procedures. They had to have typical GERD-related symptoms, so looking at patients with atypical manifestations or extraesophageal manifestations were not considered to be good candidates for these type of studies. I'm not saying that studies were not done in these patient populations, but in general, in the approval studies, they were not included. And they couldn't have any other abnormalities. So you could see it's a very specific patient population. Now let's start with the plicator system. So this system has been around for a long period of time, and you can see that it includes an instrument called the plicator. And the plicator had 2 pledgets, you can see left and right, and in the middle there was an endoscopic tissue retractor. The scope per se is served as a way to look and how to perform the procedure. So it allows you observation while you were doing the procedure itself. The idea was to put sutures and to create a valve. And at the end, at 200 to 300 degrees of anterior fundoplication. But the problem was that you were using regular sutures. Now let me show you how it looks, this type of procedure. Can you start the video, please, for me? Well, there was supposed to be video here. Okay. The video was supposed to show you how the procedure was done. But this is one of the first studies that looked at the plicator. This was a 3-month follow-up. Patients were randomized to either sham or procedure. And the sham was just performing an endoscopy without letting the patient that nothing was done as compared to the procedure itself. You can see the value at baseline in relation to the percent of patients using PPIs. And the plicator significantly reduced the number of patients that were using PPI as compared to the sham. Here, you look at the median percent time pH less than 4, and again, the plicator was able to significantly reduce the percent time pH less than 4 as compared to the sham procedure. This study, in fact, looked at the effect of the plicator on acidic and non-acidic reflux, in this case, acidic, weakly acidic, and weakly alkaline. For some reason, the acidic reflux did reach statistical significance. After the procedure, there was a significant reduction, something that the weakly acidic and weakly alkaline did not reach. But there was a reduction. There's also evidence that the procedure significantly reduced liquid reflux and then mixed reflux, which is the most common type of reflux that we see in our practice. So everything looks good so far, at least in the short term. But the problem started when we started to look at studies that evaluated the procedure long term. And this is a 4-year follow-up in patients that underwent the plicator. In this procedure, they looked at drug use as compared to baseline. And you can see that the 3 months showed that there was a certain level of drug use, but it increased after 4 years, suggesting that somehow the procedure failed over time in a subset of patients, and as a result, they required retreatment with anti-reflux medication, maybe suggesting that the suture are not that durable in this patient population. This is also a 4-year follow-up of endoscopic gastroplacation for the treatment of GERD, and you can see that the proportion of patients that actually improved during, as a result of this intervention was reduced significantly over time to almost half of those that felt better after the procedure at the beginning. So there is a significant number of dropout over time. And we believe that the reason for that is the type of sutures that are used with the plicator. They are likely not that durable, and over time, patients may lose effect. So let's move and talk about the other procedure. This is the Strata device. That's been around for almost 20 years. However, the original device that was introduced during 2000 is not the same as we have today. There were many improvements. And what it does, you can see that there is a balloon, and the balloon is placed at the lower part of the esophagus, at the GE junction, and there are needles. So when the balloon is inflated, these needles actually are introduced into the esophageal mucosa, and radiofrequency is delivered through them, creating some type of narrowing in the lower part of the esophagus. So this is one of the earliest studies. This is a randomized, double-blind, placebo-controlled trial. And in this trial, patients received sham intervention, meaning they just had an endoscopy, they did not have the Strata procedure, as compared to those that received the Strata procedure. Small number of patients in each arm, as you can see. But what it clearly showed that the procedure significantly improved subjective parameters, but did not significantly improve objective parameters, even though when you look at the number, there was, the numbers posted in the active arm were lower than those that received sham. Now this is results of a meta-analysis that looked at all the studies that were available at the time. Either they were randomized controlled trials, various observational studies, longitudinal studies. They included all of them in this meta-analysis, and this time looking at the subjective and objective parameters. You can see the number of studies, the number of patients in these studies, the mean follow-up, the pre-Strata values, post-Strata values, and you can see that in all of the parameters, objective and subjective, using this type of meta-analysis that included not only the randomized trial, but also the observational studies, there was a statistical significance, suggesting that the Strata works in all parameters that I mentioned to you, that when you perform these type of studies, these are the parameters that are commonly used. Now, this is a study that was done by Dr. Richter, and in this study, this was a meta-analysis that looked at the Strata procedure, and in this meta-analysis, they included only the randomized controlled trials. And unfortunately, there were only 4 that were done over the years. So it's a meta-analysis of a very small number of trials. And when you look only at the randomized controlled trials, you can see, at least in these 2 parameters, which is ability to stop PPI or health-related quality of life after being off medications, so before and after the procedure, then you can see that it didn't make it in these 2 important parameters. This is a meta-analysis that I've done, but in this meta-analysis, we looked not only at the randomized controlled trials. This meta-analysis was published, in fact, last year, and it included also all the observational trials, including some follow-ups 10 years later in patients that received the Strata procedure. So it included 28 studies and almost 2,500 patients. And it did show, this meta-analysis, that the Strata procedure was able to significantly reduce esophageal acid exposure time, significantly improve erosive esophagitis incidence, significantly improve heartburn score, significantly improve health-related quality of life score, and significantly improve the number of patients that were using PPI. It did not have an effect on lower esophageal sphincter basal pressure. But one of the main criticisms that not only the Strata procedure received, but all the other endoscopic therapies, is the fact that when you look at esophageal acid exposure, you can see that in most of these procedures, you cannot normalize esophageal acid exposure after you perform the procedure, and even if you follow these patients over a long period of time, that their esophageal acid exposure remains to be abnormal in most of these patients. And that was raised as a fault or a problem with this type of procedures. My argument about this is that if patient symptoms improved, there was a reduction in esophageal acid exposure, then I'm not really worried if their esophageal acid exposure still remained somewhat abnormal, because most of the time it was only mildly abnormal. So I'm not really looking at normalization of esophageal acid exposure. In fact, when you look at the PPI trials, none of them really followed the patients and demonstrated normalization of esophageal acid exposure if these patients reported symptom resolution. The adverse events, this procedure appeared to be relatively safe. There are adverse events that have been reported in the literature, like small erosions or mucosal lacerations, but if it's done in the expert hands, it's a relatively safe procedure. The next procedure is the ESOFIX, or TIF, transoral incisionless fundoplication. Again, using the scope here to observe on how to perform the procedure, where you have the technique itself. And what you do is you create, again, a valve using fasteners rather than sutures. So that's the difference between this type of procedure and the applicator. You put about, on an average, about 20 of them, and you create a 3 to 5 centimeter valve in the lower part of the esophagus. These fasteners are between the lower part of the esophagus and the fundus. And in addition, you created 200 to 300 degrees of anterior fundoplication. Early studies clearly show that this type of procedure significantly improved patients' symptoms. Here, when you look at GERD, health-related quality of life, you can see how it was on PPI. Before the study, they took the patient off PPI, it went up to 25, and after the procedure, it went down significantly to 4. You can see also the discontinuation of daily PPI in ITT was 61%, 74% per protocol. Normalization of esophageal pH was 82% per protocol and 39% ITT. This is a recent study, and what it did, they looked specifically at patients with gastroesophageal reflux disease where regurgitation was the predominant symptom. They randomized the patient to the TIF procedure, and then they became placebo. They followed them for 6 months, or patients received the sham, where they just did endoscopy, no intervention, and then they were treated with PPI over that period of time. And you can clearly see that those that received the TIF versus those that received the PPI did significantly better in 3 objective parameters related to esophageal acid exposure. One of the early studies, and this is looking at the early type of the ESOFIX before they clearly improved the technique itself, just to show you that when these procedures come to the market, sometimes they are not really ready for prime time. They looked at 19 patients. Again, the criteria for inclusion in this study was the same as I mentioned initially. And in these 19 patients, 3 of them had major complications. And after follow-up of 10.8 months, 10 of these patients had to be converted to left fundoplication, 9 were dissatisfied with the outcome, 68% consider it unsuccessful. So early studies with this type of technique were not that positive, but over time, as they changed the technology, improved on it, the results are much better. This is a study that looked at all the publications related to the TIF procedure. This was recently published. It's a meta-analysis. 18 studies, almost 1,000 patients, and they looked at the pooled relative risk of response rate, which was 2.44. However, they found out that the total number of refluxes was reduced, but esophageal acid exposure time and acid reflux episodes did not reach statistical significance, as we see with all other endoscopic techniques. The PPI usage increased with time, which is obviously another observation that we have in relation to this type of technique. The total satisfaction rate after TIF was about 69% in 6 months, when one would expect it to be higher. And the incidence of severe adverse events consisting of GI perforation and bleeding was 2.4%. They concluded that TIF is, while it is an alternative intervention in controlling GERD-related symptoms, that long-term results showed decreased efficacy with time, and patient often resumes PPI at reduced doses, and which is part of the problem that we see with this type of procedure. This is a meta-analysis that was done also by Dr. Richter and was recently published in Gastroenterology, again showing that the procedure itself did not have the efficacy that one would expect, and with limited effect on a variety of objective and subjective parameters. They concluded that laparoscopic Nissen fundoplication has the greatest ability to improve physiologic parameters of GERD, including increased LES pressure and decreased percent time pH less than 4, although TIF procedure had the largest increase in health-related quality of life. This could be due to the shorter follow-up time of these patients. Now, I'd like to talk about the last procedure that was recently approved. This is the latest arrival into the endoscopic intervention market, and is called the Medigas procedure. It's a very interesting technology because you look at what they were able to pack at the tip of the scope. They were able to pack an ultrasound, a miniature camera, and a stapler. This is all at the tip of the scope. They have already early studies that clearly show significant improvement in health-related quality of life, decrease in the PPI consumption by medication, improvement in the mean percent total time pH less than 4, and overall the procedure appeared to be safe, obviously in the expert's hands. And they have also a long-term follow-up that suggests that these findings that you have already in the short term, you can see in the long-term follow-up. Obviously, we need randomized controlled trials with this type of procedure, which are still not available. So when you look at the comparison of the different procedures for GERD, you can see that the strata is under conscious anesthesia can be done. You can look at the cost. It does not require hospitalization. You can see the 10-year data is available and very few reported adverse events. The TIF is done under general anesthesia. You can see the cost. It requires maybe 1 day hospitalization. Still no 10-year data. The Muse is relatively new. General anesthesia, you can see the cost. Hospitalization, at least 1 day, and some reported adverse events. And I will not talk about the LINX procedure because it's a surgical procedure and not endoscopic. So I'd like to summarize here that sphincter augmentation procedure offer an alternative to medical treatment of GERD, so it's something to be considered. Interest in endoscopic procedure has been growing because of patients' concern about long-term PPI treatment and the desire for alternatives to surgery. So patients are not excited to go to surgery today as they used to in the past. They want something in between, and these type of procedures truly fit it. Long-term efficacy, especially objective clinical endpoints, remains to be determined in many of these procedures, and expertise of the operator, reimbursement, and adverse events are limiting factors for their use. Thank you very much.
A lot of people in the audience, you look like you're really, I know you're great clinicians because I've dealt with you. I know you got questions, but some people are going to have to come up to the microphone. But to start this out, and I would suspect the most controversial of these talks is Dr. Foss's discussion of alternative treatments. And we're actually, I think, during this period, we'll talk a little bit about the links and we'll talk about the Nissen fundoplication. So let's start out by just taking a survey, okay? How many of you all here in this community have availability and or send patients for the Nissen fundoplication? All right, put your hands up high. How many? Okay, all right. I mean, it should be nearly all of you because that's the gold standard operation. How many of you are sending the patients for the LINX operation now? Okay, put your hands up high. So we've got not as many, but still a good response. How about for the TIFS operation? How many of you are sending patients for the TIFS operation? Would that gentleman please stand up? No, you don't. Put your hand up a little higher so we can see it. Ronnie, put your hand up too, because you got to be doing. Okay, so you got two of you here. I know there's been enthusiasm over the years in South Florida for Stretta, so I'm going to put your hands up. How many of you have sent patients for Stretta operations? Yeah, I knew there were some. We got two ladies over here. Oh, and yourself. Okay, so. Maybe Ronnie, I'll start out, but I want Michael to chime in, and I will too, because you had a hard time in your summary of selling me on this business. I guess the issue is the two things that we talk about most in this is because you can do it, who would you do it on? Because we have other good operations. But the two things I've always been concerned about most is what is durable? How much durability do you want in the life of a GERD patient because they tend to have a normal life expectancy? And number two, how in the world do you get people to pay $2,000 to $6,000 if insurance companies aren't paying? So maybe help us with that. Maybe Michael could make some comments too.
So durable is a good question, but I have to remind you, Nissen fundoplication is also not durable. Okay, you send patients to Nissen fundoplication, you're not looking at long-term response. I mean, you have to be honest with your patients, and you have to tell them that they may be looking at 10, 12 years, maybe not. So durability is an issue, and it's not only limited to endoscopic therapy. So from that, I would like to have lifelong, obviously. Whenever I do an intervention, endoscopic surgery, I like to see it working for the patients lifelong. That's also what patients expect. That's what they would like to see. So in my mind, durability is something that is desired, and the hope is that we can keep the patients from coming back in with either complications or that the intervention is not working anymore. We can keep them away from the clinic and the hospital as long as possible. Now, how can I convince patients to pay if the insurance doesn't cover? It depends on the patient population that you have. Now, some of the patient population will do it, and especially if they have the money and are willing to pay from pocket. I work in a place where I have a very diverse patient population. Many of them cannot afford it. And so we won't be able to do in these patients. But I think the concept of having options is something that patients are looking for. And the other thing is, patients are not jumping today into having surgery. In fact, we were able to show in a recently published study, and you also have shown that in another study that you published, that there is a significant decrease in the number of fundoplications that are performed today around the United States. The main reason for that is both patients and physicians are not in a rush today to send patients for fundoplication or any surgical intervention, and they're looking for something that is in between medical and surgical therapy.
Yeah, Michael, and particularly maybe comment, and we get a little discussion going about the LINX operation also. I don't know how much experience you've had at Vanderbilt with that.
Yeah, I would take maybe looking at it slightly differently. I don't think that it's good to have choices and options, but I would look at it slightly different in that I would say, why would anyone that's doing well on a PPI want to do something different? right? Isn't it easier to just take a pill and your symptoms are better? To Ronnie's slides that he discussed about all these associated risks, I think I would just discuss with the patient about those, put those in perspective. If they still want something different, then we would have a discussion on this. But I would be cautious about necessarily suggesting anything other than a PPI, if you will. When you look at it, I think it was a 2004 surgical study that Nimish may have done. It was published in American Journal of Medicine. This was a while ago now. They asked patients that had surgical fundoplication, why did you pick surgery? Most of them said, because I thought it was a cure for my reflux. So what patients want is, as Ronnie was saying, something definitive, but I think that's where we come in. There is no definitive, right? Fundoplication fails. These endoscopic interventions fail. Links potentially could have implication as far as erosion, but they all also work. But they have limitation. They work for a short time. Over time, patients may go back on their PPI. So if you educate your patient that you could take your PPI, yes, there are these associated risks, but here's the perspective. You could have LINX operation, you'll do well, but you could have dysphagia, it could erode, you could have TIF, you could have LINX, you could have any of those for a short time, then you're back on your PPI. Or you could have surgery and you could have gastroparesis because of surgery or dysphagia because of it. If you put it in perspective, I bet you most of the patients will say, well, why wouldn't I just take my PPI? So that would be the argument that I would have, is just providing options is good, but also providing perspective is the key for your patient. So the LINX operation is surgical, it's laparoscopic, it is easier. They fix the hernia as they put the beads in. It works well, but it doesn't normalize acid reflux. Patients do well. It could erode. So I would say all of these endoscopic and or minimally invasive surgeries have shown efficacy. They're promising, but I would put it in that perspective.
Yeah, one of the things that we struggle with, and in fact we've put together a society that I think Ronnie was at, and I was one of the board members, American Foregut Society, really getting gastroenterologists and surgeons and endoscopists together to talk about the treatment of esophageal disease, because there's a lot of esophageal disease out there. And there are a lot of good things that we can do on these patients, and obviously we wrestle with the strange time in this country, and I'm not talking about the politics, I'm talking about PPIs actually, is we've got drugs out there that I had the pleasure of being one of the original investigators when I was in North Carolina, so we started our original investigations in 1985. So we've had drugs that we've had for nearly 40 years, and I think, nearly all of us are very, very convinced about the safety of these medications, but these annoying studies that are population-based but not person-based, and these advertisements and what to do with that. So, our patients are asking about it, and I think these are questions you've got to get comfortable about. It was interesting at this conference, the way the surgeons were talking about it, and it helped me a little bit because I'm not pro-endoscopic treatments, as you can tell from the articles we've published. Certainly in randomized studies, when you do meta-analyses, they're not very vigorous. The data is not very robust. But they were talking about depending on what the patient's need is. If the patient is someone that's got an acid-sensitive esophagus, not much reflux, and they're paranoid about PPIs, and there are people out there, that, then maybe the Stretta would be a nice thing, because the Stretta is fairly simple. Complication rate hasn't been too high. We've had that for 20 years, and it does not only maybe bulk up that area, but also maybe does some type of a neurogenic and affects the sensation, but they don't have much reflux, not to worry about it. The TIFs, I tell you, the problem I think with the TIFs is even those H fasteners don't hold. That esophagogastric junction is constantly moving up and down. If you're coughing, if you're exercising, and if the sutures the surgeons put in, done laparoscopically or open, don't hold, it doesn't surprise me that those don't work. But there's some enthusiasm, I think, across the board, at least at this meeting, in the patients with regurgitation.
and particularly in patients with regurgitation that might not be good candidates for real operations. And then the LINX and the Nissen becomes not the perfect operation, but the more durable operation, with the LINX evolving, probably being in reality a more easy operation to be done in the community maybe than a Nissen. But I think we're all coming down to the same thing. We don't have the perfect operation yet. PPIs are still very safe. And remember, I don't think we have to say it to this sophisticated audience. If you can't figure out what's going on in your patient, don't feel like the surgeon's going to help you, okay? If they're intractable to PPIs, you better study them very carefully, because most people that are intractable to PPIs have functional heartburn, and functional heartburn does not do well with anti-reflux surgery. Ronnie kicked me in the shin. He has another comment to make or two.
Yeah. So, no, I think I wanted to make a comment related to what Mike said, because Mike raised a very important point. And the fact is that if patients do well on PPI, then why rock the boat? So this is not really for the patient that are doing well on PPI and they're content with that, obviously. We don't want to, I mean, we're not selling it in our office saying you have to do it, forget about your PPI, because then we show them one of these anti-PPI websites. I mean, at the end of the day, we're physicians. We're trying to do what is the best for our patients, and we have to work with our patients. And also, I think that for the success of these type of procedure, patients have to be motivated. So patients have to want it. They have to be motivated to have it. These are patients that are not interested in chronic PPI treatment. They come back to you and they say, I'm looking for something else. Do you have something else? Or I read about this type of procedure and I think I don't want to take my PPIs. I'm concerned about all these side effects, and I'm not interested in surgery, and I want to have one of these endoscopic procedures. So just to make sure that you understand that we're not selling those procedures in our practice. We are offering it for those patients who are interested in that.
Michael, do you offer TIFs or Stretta in your practice at Vanderbilt?
We do as well. So we have LINX and we have Stretta that our surgical colleagues do perform. I mean, to that point, I agree with you. There will be some, no matter how you try to convince them that these reported associations are, just associations at best, do, stay on it. If you have a patient, as long as they're making this decision in an informed fashion, an option is good if it's made in an informed fashion, i.e., you're going to be back on your PPI in 4 years. So if you're a patient concerned about taking a PPI chronically, and then I'm telling you, you could have this as an option, but in 4 years, you're going to be back on that PPI, I don't know if that patient's going to take that option, to be honest with you, because if it's a year, 2, 3, 4, so as long as they make it in that informed fashion, you're right, Ronnie, because we can't make that decision for them.
And finish up, I mean, we don't offer that at University of South Florida. You come to see us, you'll get a LINX and or a Nissen fundoplication if you have GERD. We'll stay with this theme a little bit, Ronnie. The question asked is, has these endoscopic techniques been studied in Barrett's patients?
So they've been, so they're not indicated, first of all, in Barrett's patients. There are some concern in performing them in Barrett's patients. But it has been proposed that maybe they have a role in Barrett's patients in order to reduce reflux in these patients. But remember one thing, none of this procedure, as I mentioned, especially when it comes to Barrett's patient, has been shown to normalize esophageal acid exposure overall. In some of the studies, there were attempts, especially when you treat these patients with anti-reflux medications, is to try to bring down the esophageal acid exposure as low as possible. So at this point, the answer is no.
This is a combination question. I'll give it to Michael, because I think it is an important question relevant to which patients will do better with real surgery versus endoscopic treatments. And part of the question is, how much does a hiatal hernia contribute to heartburn? and what to do about that. And the other part is actually someone in the audience talked about a patient who, despite being on PPIs, has a large hiatal hernia and is still having reflux. So really, Michael, the essence of the hiatal hernia and what surgery does to really change that.
Yeah, so it's important to know that most of your patients, the reflux symptom that they're having and the acid exposure is not from a hernia. It's from transient LES relaxation. So that's number one. Number two, in a patient that has a large hernia, has heartburn regurgitation, at best what you can do is help the heartburn, less the regurgitation, because that's a volume phenomenon, right? So regurgitation is a volume coming from the stomach up, and the hernia is allowing that to happen because you don't have the LES competency anymore. So unfortunately, your PPIs are not going to help that. And if a patient is symptomatic with regurgitation, getting back to what Joel was talking about earlier, you know, you can give PPIs till the cows come home, if you will. That regurgitation is not going to get better. That's where then you could reach for your surgical colleagues' help. So a patient with heartburn improved on PPI, not regurg, surgery could be an option. You could also have links as an option because they would reduce the hernia, although if it's a moderate to large size, that becomes less of a problem or an option. So that would be where surgical fundoplication comes in.
Okay, we'll switch a little bit. There's a question to me, and a very practical one. How do you manage esophagogastric junction outflow obstruction if you don't have the time-barium esophagram available or the endoflip? Well, in essence, you have an element of the time-barium esophagram because all your radiologists are trained, I hope, in doing barium studies. So you have the esophagram available. So all you have to do is ask the radiologist in that situation just to assess after they do their full esophagram. And remember, most of them now are pretty attuned in dysphagia patients to give them a 13 millimeter tablet. Before they give them a 13 millimeter tablet, ask them just to give a little bit more barium in the upright position, see how it goes through, and follow that with a 13 millimeter tablet. The endoflip, this is really being pushed very strongly by Medtronics. We do not have endoflip. I know Michael doesn't. Ronnie,
I don't.
You know, new technology is great. I'm always excited about new technology. All three of us have been involved in development of new technology. This is not ready for prime time. It is very expensive, $40,000. It still is, normal values have not been well developed. Medtronics is selling it hard for that reason. They'll probably give me a call after this meeting as a result of my comments. But I'm excited about it. But right now, I think it needs to be in the esophageal centers of excellence. We're actually getting involved in a large multi-center study. And one of the things is just to develop the normal values and what it is and all of that. So keep an eye on it. I think it'll be 5 years before we really know how to utilize it, but the time-barium esophagram is available. If you don't have either of them and you've got somebody with outflow obstruction and their major symptom is dysphagia and regurgitation, Botox them. Simple, easy to do. Everyone in the community is familiar with Botox. Again, thinking of this as a variant of achalasia. The problem you have, just like with achalasia, it's a shame when you Botox them to death. Now, if they're going to die in 2 years, Botox is cost effective. But if they're not going to die in 2 years, you're eventually going to have to do something more definitive in these patients, like we do in our achalasia patients. A question. Someone from the audience. Thank you, sir.
So we see a spike in the number of referrals from pulmonary doctors who are evaluating people with chronic lung disease, asthma, ground glass, interstitial pneumonitis. And those patients frequently are asymptomatic from reflux, but they're anticipating we're going to find silent reflux and perform a LINX procedure. Wondering what your experience has been in that subset population.
Michael, you want to comment?
Yeah, so that's an important group. I agree with you. You know, this issue of silent reflux, any surgeons in the audience, by the way? Gastroenterologists. Okay, so the idea of silent reflux, and I say this to be critical of us, the non-surgeons, because we tend not to believe in silent reflux. We tend to say, because our background is heartburn regurgitation defines the disease, right? Then we realize, well, what is reflux? Is it symptom or is it physiology? If you have someone that has abnormal reflux by physiologic tests, but yet has no symptom, is that reflux? So that's where the issue comes. Patients with asthma, there's a large subgroup of patients with asthma that will have abnormal reflux by pH testing. 70 to 80% of them will have abnormal reflux if they have their BMI is above 25. So if their BMI is above 25, 70% will have abnormal reflux defined by pH greater than 5%. Now what do? Right? So, because the question is not whether they have reflux. The question is that reflux contributing to their worsening asthma or lung disease? That's a tougher one to call. Some of the non-controlled studies suggesting really what you go by is the hernia regurgitation. If there's evidence of that, then the only thing you have to offer would be surgery in that group. And I would say 90% of patients in that group do not have large hernia, do not have regurgitation at nighttime when they sleep. Therefore, it's that 10% that you got to say, would surgical fundoplication help their lung disease? We don't have that evidence, but that's the group I send to surgery, usually that 10% with significant reflux and a large hernia.
Could you be even addressing that if you can control their reflux, they can improve by pH probe with acid suppressive therapy?
Yeah, so the question you're asking is, can you repeat that?
Yeah, so let's say you do the pH probe on these patients that refer to you, and you show that there's reflux, but you also show they respond to acid suppressive therapy. Should they even be considered?
No. If you show that it's acid and or non-acid is controlled, there's not a large hernia, you're done. Your role as a gastroenterologist is done in that you've controlled it. It's the uncontrolled group that I'm talking about, the 10%, where you gave the PPI, acid may be controlled, they're regurgitating at night, they're aspirating, your asthma doctor or your lung doctors are saying this is contributing to their lung disease, that's where you consider surgical fundoplication.
I think what makes all these extraesophageal diseases so difficult is with asthma or cough, there's so many other factors that be contributing. And I tell you, this is where our divided healthcare system gets so difficult because of the fact they'll see the pulmonologist and they'll do their pulmonary function test and their CAT scan. They'll see the ENT doctor who almost invariably says there's acid reflux. They'll see their allergist. Yeah, it is a difficult thing. I think the one area that we all agree on that, it really, this silent reflux may well have a pathologic aspect is in the people with interstitial pulmonary fibrosis and lung transplants. And there, interestingly, it's probably not the acid, it's probably not the weak acid, but it's probably the bile salts that they're refluxing. We're using that as a surrogate. And that's why it's very important if you're working in any association, either in the community or in academics with people who are doing lung transplants. This is where the impedance pH technology, I think, probably is somewhat superior, and studying these patients before they have transplant surgery, study them afterwards, and making some decisions, because obviously in that group, the two things that are most life-threatening after the lung transplant are the recurrent infections and the reflux that they have. Michael, you haven't had anything directed your way, so this is the closest I can get. How to treat erosive esophagitis post-gastric bypass not responsible to double-dose PPI? That's a good question.
Yeah, so anytime you see esophagitis, so first of all, depends on what type of surgery you're talking about when you say bypass. If it's Roux-en-Y, that's different. If it's sleeve, that's different, right? So when you say esophagitis, we often think of acid causing it, acid plus pepsin causing it, right? But in a patient with Roux-en-Y, they only have 5 centimeter segment of stomach. So if there's esophagitis, is it really acid related, or could it be something else? Remember, other things can produce esophagitis. Is it pill-induced? Is it infectious esophagitis? Is it cancer? Is it all the other things that we know of? Is it really an anastomotic stricture with ulceration, which is an ischemic issue in that subgroup of patients? So all of the things that you should consider. So I'm not convinced it's acid per se, that the acid peptic disease, if you will. So I would love to hear from you guys what you think in that group. Ronnie?
So, I mean, this is in relation after gastric bypass?
Bypass, yeah.
Yeah.
It's just a gastric bypass.
Yeah, gastric bypass, in fact, I think also Mike mentioned it in his presentation. Today, if I have a patient who is morbidly obese and they have reflux, I do not offer them fundoplication. I think that the best thing they should go is gastric bypass. So it's really a non-refluxogenic surgery. There are many studies that look into this, and it's very clear as compared, in my mind, to sleeve gastrectomy, and I think Mike also emphasized that. So I agree with Mike. If you see somebody that despite the fact that they had gastric bypass, they still have what you think is erosive esophagitis, then the first thing I would look to see is if there is a stricture or narrowing somewhere down the line that increase, for some reason, the pressure resulting in some reflux of content back into the esophagus. Otherwise, I would look at other reasons, medications like Mike mentioned, especially NSAID use, aspirin use, and others. That's what I would look. I'd like also to mention one comment about sleeve gastrectomy, because in my mind, this is a very refluxogenic surgery. And we see now more and more studies showing that a lot of these patients develop severe reflux post-surgery. There are some studies showing up to 50%. There are also studies showing new Barrett's esophagus appearing in these patients. And we have a study that it also increases the risk for esophageal adenocarcinoma. So I just wonder what's going to happen in the future to this type of surgery, and I can say it confidently because I know there are no surgeons in the audience.
Well, we got another question, good.
That was my question, actually. So this is a patient I was involved with, had Uruguay, also had endoscopy and Bravo placed at the same time, and has erosive esophagitis and markedly abnormal acid reflux from her pouch, apparently. I mean, the scores were very high.
Well, that's
And she was on double dose of omeprazole before.
Yeah, I mean, it goes back to physiology to me. If there's severe esophagitis in a patient that has no stomach, what you think of is bile reflux by itself, but it's not in a Roux-en-Y gastric surgery where bile is being diverted way distal in the small bowel. So that's not going to be the case. Now you're looking at what else is contributing to it. So I would not, PPIs are not going to help that patient population. Is it infectious? Did you biopsy it?
It was,
Well, but it had an acid reflux, abnormal.
yeah, very abnormal.
Did they have an abnormal pH study?
Abnormal pH.
Yeah, so, it turned out probably the pouch was larger than planned, maybe.
Yeah,
Yeah,
that's
so what is the size
And
of the pouch?
basically, you're probably going to end up resecting that pouch and converting it to a esophagojejunostomy of some sort like that, yeah.
Okay, thanks.
I mean, we saw that in the VA days, remember, before the PPIs, where we were doing the antrectomies and the various things. We thought we got rid of all the acid, but we really didn't. So it does happen, unfortunately, but rarely. So we're going to end that. I thank everybody for the excellent presentations, for the questions, those that volunteered to ask questions. And we'll have a little time after that if you'd like to come up and talk with us personally. Thank you very much.
I'm going to be speaking about fatty liver disease, and in contrast to the usual talk in this topic, I'm not going to show you a map of the world with the rising prevalence of obesity across the globe. So what I'm going to do, however, is focus on some key clinical issues in fatty liver disease: how to distinguish steatosis from steatohepatitis, the potential for progression of patients with steatosis alone, should we do genetic testing in patients with fatty liver, who to screen for hepatocellular carcinoma, lifestyle modifications for patients with NASH, and current pharmacological approaches to NASH. Now, one of the key issues in evaluating an individual patient with fatty liver is whether or not they're at risk of progression, and the major predictor is the amount of fibrosis present. So as in a lot of chronic liver disease, a big part of the initial evaluation is determining the extent of fibrosis, because in this and in most other liver diseases, it predicts the likelihood of complications. Now, this illustrates the various histological stages of fatty liver disease from stage 1 to 4, and on the left there isn't a lot of fibrous tissue, but there's quite a bit of fat, and then over on the right, as you can see, there's a lot of fibrous tissue in blue, but relatively little fat. And one of the observations is as the fibrosis becomes more extensive, often the amount of fat diminishes, and that's particularly pertinent in liver transplant because often the native liver may have relatively little fat, even though the diagnosis is confidently felt to be non-alcoholic fatty liver disease. Now, a key issue, again, is distinguishing the patient who just has bland steatosis from the patient who has steatohepatitis, they have inflammation and often fibrosis, because it's the latter group that are at risk of progressive liver disease. And as you know, there are a host of tests available to evaluate both steatosis as well as fibrosis. And most of these patients start off by having an ultrasound, but they need to have at least 20% fat content for the average ultrasonographer to pick it up. We heard quite a bit of about FibroScan yesterday, and that now is become part of the routine evaluation of patients with non-alcoholic fatty liver disease. And very importantly, there are some nuances related to that, including the size of the probe. So what we use is so-called CAP technique, which quantifies not only the amount of steatosis, but it also quantifies the fibrosis. There are a variety of other imaging techniques, including an MR technique that's becoming increasingly available. But again, most patients start off on an ultrasound and progress to a FibroScan. There are various formula, such as the APRI score, or a variety of blood tests that are available to assess the amount of fibrosis present in an individual patient. But I think in routine practice, if you have access to elastography, it's probably the single most useful test. And again, not only are you interested in confirming the presence of fat, but also trying to predict the amount of fibrosis present. Now, interestingly, I spent many years biopsying patients with hepatitis C to come up with a reason for not giving them interferon therapy. And now I think probably the commonest reason we do a liver biopsy in a non-transplant patient is to resolve some conundrum or discrepancy in their workup for fatty liver disease. Sometimes the FibroScan looks like they've got a lot of fibrosis. In contrast, most of the other tests look pretty good. So we actually biopsy not a lot, but some of our fatty liver patients, if we can't non-invasively determine the amount of fibrosis present. Now, what is the risk for progression of patients with steatosis alone? Again, I mentioned the patients we're more concerned about are those with steatohepatitis. They have inflammation and often have fibrosis. So can we be reassured about a patient with just bland steatosis? And this is a fairly small series, but these patients had serial liver biopsies performed over a period of several years. And for instance, in the patients with bland steatosis on the top right there, the interval between biopsies was about 5 years, which we knew was the amount of time it took a patient with hepatitis C to progress from one stage to another. And reassuringly, patients with bland steatosis, so little or no inflammation, had a low risk of progression. Importantly, however, portal inflammation and not just fibrosis also predicted an increased likelihood of disease progression. Typically, patients who progressed were older, had higher BMIs, more weight gain, and more diabetes. And in many of these patients, obviously, there are a variety of factors implicated in the development of fatty liver as well as its progression. Most of the patients have many of the features of the metabolic syndrome, including hypertension and dyslipidemia. And again, these patients may be more at risk of progression. Now, the next issue is, should we do genetic testing in patients with non-alcoholic fatty liver disease? There are a variety of genetic tests that are in various stages of development. This particular one, PNPLA, is on chromosome 22, and it's been implicated in accumulation of fat and liver injury, and it's more frequently detected in Hispanics. This is what the liver societies currently recommend, and in essence they say that these are research tools and probably are not necessary in clinical practice at this point in time. And even if a patient does have this mutation, in our current state of affairs, I'm not sure if we would manage them any differently, perhaps be a little bit more vigilant about disease progression. But I think these genetic tests will come, and they will be commercialized and introduced into clinical practice in the future. Now, the next issue I want to talk about is who to screen for hepatocellular carcinoma. And obviously, in most circumstances, we focus on screening patients with cirrhosis, with the important caveat that patients with hepatitis B are also at risk of hepatocellular carcinoma, even in the absence of cirrhosis. There have been a number of recent publications, however, which have described the recognition of hepatocellular carcinoma in the absence of cirrhosis in patients with non-alcoholic fatty liver disease. And this is a big study from the VA system, and as you can see that many of these patients had acknowledged factors for liver disease such as hepatitis B or C, but very importantly, the group over on the left there, the fatty liver patients, at least a third of these appear to have an absence of cirrhosis. Now, these weren't people with steatosis, bland steatosis. They had various degrees of fibrosis, but it does suggest that we may need to think about screening for hepatocellular carcinoma, even in the absence of cirrhosis for at least some patients with fatty liver disease. So again, here are what the liver societies say. The American Association of Study of Liver Disease does not mention it in the most recent reiteration of the guidelines, which came out last year. And in the European guidelines, again, they didn't recommend screening non-cirrhotic patients at this point in time. They also made a mention about that genetic marker, which I described a few slides ago, suggesting that that may predict an increased risk of hepatocellular carcinoma. So again, this is evolving, but I think the prudent thing to do is, if you've have a patient with steatohepatitis and you've demonstrated that they have extensive fibrosis, I would think about some form of surveillance. The sort of person I have in mind is somebody who's stage 3 out of 4 disease. I think it's appropriate to at least discuss a twice-yearly ultrasound and maybe an alpha-fetoprotein in that patient. Now, the next issue is the treatment of non-alcoholic steatohepatitis. And I apologize, I've been flipping between one term and the other. The steatohepatitis is the more severe form of non-alcoholic fatty liver disease and implies the presence of inflammation and scarring. So this is again, statement from the ASLD guidelines. The management of non-alcoholic fatty liver disease should consist of treating liver disease as well as the associated metabolic comorbidities. Pharmacological treatments aimed primarily at improving liver disease should generally be limited to those with biopsy-proven NASH and fibrosis. And certainly one of the phenomena I notice is that a lot of patients who I see for the first time have started themselves on vitamin E. Now, lifestyle modifications advocated for all patients with non-alcoholic fatty liver disease, and in essence, a patient needs to lose about 10% of their weight to impact fatty liver disease, because in most of these patients, a high BMI is a major factor. Obviously, we discourage the use of alcohol, but what I tell patients, this is part of a much bigger issue, because most patients with fatty liver disease do not die of their liver disease, they die of cardiovascular disease. So if somebody's got fatty liver, what that tells you is that they've got an adverse cardiovascular profile, and they need to try to address all the precipitants, including their weight, lack of physical activity, and so on, to mitigate their cardiovascular risk as much as their risk of progressive liver disease. Now this shows the treatment that works best for fatty liver disease, which is weight loss. And very importantly, patients needed to lose at least 7% of their weight to have an impact on their histology. The maximum benefit was seen with a weight loss of greater than 10%. Steatohepatitis improved in all patients, and there was a greater change the more patients lost. And the final point there is very important. Patients who had worsening of liver disease were generally those patients who had little or no weight loss. So again, a key component in all of this is obviously education, and we heard yesterday how important it was to involve dietitians in the management of many of our patients. It's crucial that a patient with fatty liver disease is encouraged to see a dietitian. Now, what they don't need to do is see, quotation marks, a nutritionist who is going to put them on all sorts of magic potions that are going to take care of the problem without their changing their lifestyle. That obviously it isn't going to work. And the other thing is, I strongly discourage patients from taking a variety of herbal products, because again, they're of unproven efficacy and unknown toxicity. So if patients really want to do something about this, a big part of it is a changed lifestyle. Now, the number of different pharmacological approaches in development, and these include antifibrotics, trying to disrupt or mitigate some of the aberrant metabolic pathways, reduce oxidative stress or inflammation, and like any talk in gastroenterology these days, we need to talk about the microbiome, which I think will be an area of major investigation in this disease in the future. Now, this slide illustrates some, but not all, of the various medications which are in clinical development or have been looked at for non-alcoholic fatty liver disease. And as you can see, they address a variety of different possible approaches, including dealing with the gut, dealing with inflammation, dealing with intermediate metabolism, or trying to mitigate the consequences of fibrosis. So this looks like this would have been, 10 years ago, this is what a diagram of potential treatments for hepatitis C looked like. So there are a lot of agents in development, but right now we don't have anything that's been approved to treat fatty liver disease. Now, what to do about agents that are already on the internet and have been studied adequately in clinical trials. The first one is vitamin E. This is based on a number of studies. It did improve liver histology in non-diabetic adults with biopsy-proven NASH, and it may be considered in this population. It's not yet recommended for NASH patients with type 2 diabetes, fatty liver disease without liver biopsy, NASH cirrhosis, or cryptogenic cirrhosis. Now, there has been some concern about a possible relationship with prostate cancer, and in the earlier literature there was a suggestion it was implicated in increased all-cause mortality. I think that's been laid to rest, but one of the concerns with any medication for this disorder, it's not like eradicating a virus or treating H. pylori. These are medications probably patients will need to stay on long term. So safety really is a major concern. There's also been some interest in the glitazones, pioglitazone. Again, this was based on a large trial. It did improve liver histology in patients with and without type 2 diabetes and biopsy-proven NASH, and it may be used in treatment. But again, it should be reserved for patients who've got histological confirmation of non-alcoholic steatohepatitis, which, so somebody you're more concerned about and have encouraged to have a liver biopsy. The downside is it increases patient weight. There was also concern about a link with bladder cancer, which has not been confirmed, but it is implicated in causing osteopenia. And again, we're talking about a medication patients will probably need to take for a protracted period of time. Now, there are a variety of agents, as I mentioned, in various stages of clinical trials. This is a study of beta-cholic acid, which is now licensed for the treatment of primary biliary cholangitis. And this is the initial report on this agent. And what it suggested was that it significantly improved fibrosis and did not appear to aggravate other manifestations of fatty liver disease, with the exception it did appear to increase steatosis. So it may be that if this does make it to an indication, patients may need to be on some other additional drugs, such as a lipid-lowering agent, to hopefully reduce further accumulation of fat in the liver. So this looks promising, and it's currently in a larger clinical trial. This is another agent which it's an antagonist of some key chemokine receptors. It did appear to improve fibrosis somewhat, but it did not reach statistical significance, and it didn't significantly improve fibrosis without causing worsening of the NASH. So one of the concerns with all of these agents is that, paradoxically, you may be able to decrease the amount of fibrosis, but it may affect some other things, and in fact, you get more steatosis with the agent. So again, I think we've quite a ways to go yet before we're going to have some new therapies for the treatment of non-alcoholic fatty liver disease. Other treatments that are not currently endorsed for NASH include metformin, improves the liver test and insulin resistance, but does not improve the histology. The GLP-1 agonists, the small report with some improvement, perhaps slowing fibrosis progression. Urso has been around for a long time, and it does not provide a histological benefit. Omega-3 fatty acids, no proven benefit, but can be a therapy for hypertriglyceridemia, which is one of the precipitants of fatty liver. We've mentioned beta-cholic acid. And then probiotics, again, I think they are compounds in search of an indication, and there's no evidence as yet that they're efficacious in patients with fatty liver. Now, we heard a very nice talk this morning on bariatric surgery, and that's certainly a consideration in at least some patients. It's been proven to improve steatosis, ballooning, and inflammation, and most of the benefit occurs pretty quickly after surgery, presumably when the patients have the most profound weight loss. It does stabilize or improve fibrosis. Obviously, if the patient's already cirrhotic, bariatric surgery needs to be considered very, very carefully, because there obviously is an enhanced, or maybe an enhanced operative risk. But we certainly refer patients for bariatric surgery, and unfortunately, many insurance companies won't pay for bariatric surgery, but if a patient has significant fatty liver disease, they've already suffered end organ damage, and I think it is a legitimate indication for considering bariatric surgery. It's obviously not for every patient. And again, we're really working off relatively small series to determine which is the best type of surgery. And again, it's something we endorse for a subset of our patients. So here are the key clinical issues we've discussed in fatty liver disease. And this is just a summary slide. So all of this is going to require lifestyle modification. And I think no matter how many effective drugs we have, if patients don't address the precipitants, weight gain, inactivity, other features of metabolic syndrome, I find it very hard to imagine taking a drug for a year or two is ultimately going to change the course of the liver disease. So again, we've a major challenge with education. We need to address precipitants such as hyperlipidemia. And again, this is a field that's evolving very, very quickly. So I do believe we will have therapeutic options in the future. But again, a big part of this is lifestyle. So thank you very much for your attention. Okay, we'll have time for questions after the next talk. We're now going to move on to our next speaker, who's Roberto Furpi, who's an associate professor of medicine at the University of Florida. And Dr. Richter this morning was taking credit for the various trainees of his who were on the program. So I had the good fortune to work with Roberto when we were both in Los Angeles. I can't claim any credit for his subsequent success, and I hope my Socratic method of teaching didn't leave him with any lifelong scars. So Roberto, welcome.
Thank you, Paul. I mean, it's really hard to actually come and speak after your previous mentor, but here we go. Thank you, Maria. Thank you, Paul, for the invitation. And let me see if I can see this without my glasses. Yes, I think I can do that. So my topic is HCC and then screening and treatment. So I'm going to go over screening first. So actually, it's the fourth leading cause of death worldwide related to cancer. And are more prevalent in males and females, believed to be due to the sex hormones. In actually, testosterone seem to regulate the actually hepatocyte cell cycles regulators, increasing actually hepatocarcinogenesis compared to estradiol, okay? And that's what is believed why it's so prevalent in males. In the US, actually, the HCC incidence have been increasing threefold from 1975 to 2009, probably related to hepatitis C, and maybe that would be dropping with time, but we have more patients with fatty liver now, so we don't know really the incidence of that. The 5-year survival is really dismal. It's only about 18%. It's the second most lethal tumor after pancreas, actually. And most of the patients have pre-existing cirrhosis when they actually come to your clinic and they're diagnosed with HCC. It's the leading cause of death in cirrhosis, as you guys know. And in terms of screening, what the AASLD or our society recommend in their practice guidance is that you should probably do surveillance in patients with high risk for HCC using ultrasound and or alpha-fetoprotein. And actually the benefit starts when the incidence increases to about 1.5% per year or greater. And that's what you actually see in the actually cirrhotic patients, mainly not with the hepatitis B. The cost-effective analysis with Hep B actually shown that it became effective once that number is 0.2% or higher per year. The group that is not really clear is a patient with NAFL, fatty liver disease, patient that have Hep B and their carrier state, or Hep C and stage 3 or F3 fibrosis. And it's actually very controversial. And if you look at this is actually the HCC guidelines. If you look at the Hep C guidelines from AASLD, they recommend ultrasound screening for F3. So you figure why they recommend one thing and not in the other. So in general, they recommend then ultrasound, actually every 4 to 8 months, though the mean is about 6 months in all patients with cirrhosis. Surveillance is not recommended actually, which help you score C cirrhosis, because you guys know that the survival in these patients is going to be dismal, unless the patients are listed for liver transplantation. And maybe this is why the AASLD is recommending alpha-fetoprotein in addition to the ultrasound. If you look at this study, this is actually a meta-analysis that was published by one of the big groups in Texas. Single actually work in surveillance, and this published this in Gastroenterology in 2018. And what they actually did is follow patients with ultrasound versus ultrasound and alpha-fetoprotein. And you can see that actually with the sensitivity of 45% when you use ultrasound, you can diagnose about 4 patients out of 10. When you add the alpha-fetoprotein, that actually goes to about 63%. So you're capturing about 2 more patients with cancer when you actually use the alpha-fetoprotein. And this is actually a study that was just published. A very interesting study, about 14,000 patients using the Medicare database. And what they found is this: they actually had 3 groups. Patients that have consistent surveillance, it means an ultrasound or 2 every year. Inconsistent means a patient that have an ultrasound or 2 in 3 years period, and the patient that have no surveillance. And you can see that only 51% of the patient, actually 51% of the patient did not receive any screening in 3 years. So that's very striking. So the question is, what are we doing? Are we doing something wrong? Why patients are now being screened for hepatocellular carcinoma? And consistently, only 6.8% of the patients underwent, screening every 6 months. So it's something that we have to think about. Why we are not screening patients? Are we forgetting? Is the patient forgetting to do the ultrasound? But we have to actually do better when we do and see the study. And you can see here the percentage of survival. 3 years, it was 23% in the patient that have consistent surveillance versus 13% patient that have no surveillance. What about treatment? This is actually a little bit busy slide, but it shows you the clinic algorithm using the Barcelona clinic system. And you can see it's based on stage. That would be 0, very early. Stage A is early. Intermediate B, advanced C, and terminal D. And they use the liver function, that would be preserved liver function, or end-stage liver function means patient with significant decompensation. Also, they use the performance status, go from 0 to 5. It's a point score system, and actually 5 means that the patient is dead. I'm not sure what they use, the patient is dead, and a score of 5 because you will have no treatment, but anyway, that's the score system. And then tumor burden that go from the solitary nodule less than 2 centimeters to a non-transplantable patient with metastasis in multifocal HCC. And you can see that there's many options, from ablation to resection, transplant, chemoembolization, or systemic therapies. So let's start actually with early stage HCC. And that would be this group here. That would be very early stage or early stage A. So those are the patients that have solitary nodules or up to a Milan criteria nodules. That would be 5 centimeter mass or up to 3, no more than 3 centimeters. So normally what you recommend on these patients, and the ideal would be resection. That would be number 1, number 2, number 3. Is there any contraindication? You may go to the next one. That would be a liver transplant. But most of these patients, if they're non-cirrhotic, resection. If they're cirrhotic, you have to consider also resection on those patients. I will tell you, this is actually one of the algorithms used, and this is coming from the European guidelines from last year. And in cirrhotic patients, you have to consider comorbidities, as you know, age of the patient, decompensation, and extent of the surgery. So look at portal hypertension first. If the patient don't have portal hypertension, then you look at the extension of the hepatectomy. Is it going to be a minor surgery, less than 3 segments, or is it going to be a major surgery? Major surgery would be more usually 3 segments. And then the MEL score. If the patient has low MEL score, 9 or less, and this is a small surgery, then the risk of this is going to be a mortality is about 0.5% only. And you want that mortality to be 3% or less to be safe for the patient. When you look at the patient that have high MEL score and major surgery, that go to intermediate risk of about 9%. So when you get to that point, then you have to think about this. If this is really safe for the patient, if this is something that you want to do, and it's even worse when you go to portal hypertension. So if the patient has portal hypertension, varices, etc., then the extension of the hepatectomy, you go to more than 3 segments, is high risk, and it's about 25% mortality related to surgery. So that obviously that's a no. And then you have to start considering, obviously, the next step, and that would be liver transplant. In terms of liver transplant, remember the Milan criteria. That would be one single tumor, no more than 5 centimeters, or up to 3 tumors, none of them more than 3 centimeters, without microscopic vascular invasion and absence of extrahepatic spread. Good thing about this is the 5-year survival with transplantation for this patient is actually about 70%, and the 5-year recurrence rate of tumor is up less than 15%. So it's a pretty safe on these patients. There is actually papers that came out about 4 years ago by University of San Francisco, by Yao, and they're talking about downstaging patients that are actually above Milan criteria. And they've been very successful. And the criteria for this is actually 5 tumors. The diameter of the bigger one has to be 4.5 centimeters. And then the sum of all the diameters have to be less than 8 centimeters. So you can downstage the patient within Milan criteria and then consider transplantation of those patients. These are actually indications for transplant in terms of the AASLD guidelines. You have the T1, that would be the masses that are less than 2 centimeters. Most of the time, it's just observation. You don't do any liver-direct therapy on these patients, and you just repeat the ultrasound while they're waiting for transplant. T2, those are the patient within Milan criteria. And the AASLD recommend actually liver-direct therapy in the meantime while they're waiting for transplant. They don't recommend any specific direct therapy. It could be chemoembolization, RFA, because there is actually no study showing that one is more benefit than the other. And then T3 would be the patients that are above Milan criteria, and then you can consider downstaging those patients within Milan criteria. The problem is there is no consensus between AASLD or EASL or any of the societies in terms of the explant criteria for liver transplant. So in summary, for this liver resection, it's a treatment of choice for non-cirrhotic patients or cirrhotic patients with the stage A on the Barcelona system. An optimal candidate based on portal hypertension, remember, extension of the resection and liver function. And patient age and multifocal tumors within Milan criteria should not be excluded for surgical options. I mean, you sometimes have patients that are 75 years old that they look actually pretty good with no comorbidities, and you can probably even consider for transplant. In terms of liver transplant, it's the first-line option for HCC within Milan criteria, as we mentioned before, and tumor downstaging with bridging therapies to reduce the risk of list dropout and post-transplant recurrence. We will go out now to early and intermediate stage HCC. Now we're talking about ablation or chemoembolization. So we already talked about surgery, resection, transplant. The other options now would be either not candidate for a resection, ablation, and chemoembolization would be the next step. So what are the local regional therapies? We have mainly 2, ablation or endovascular treatment. Ablation actually could be percutaneous or laparoscopic. It could be thermal, chemical, or actually stereotactic body radiation therapy, or endovascular, that would be transarterial chemoembolization or transarterial radioembolization with yttrium-90. This is actually an early study from 2003 by Lobet in Barcelona, and they compare 112 patients that got chemoembolization, embolization, or nothing. So they have gelfone and doxorubicin, or patients that receive no therapy. And you can see here the chances of survival at 1 year was a lot higher in patients that received chemoembolization with doxorubicin than actually control. I don't have there the graph for the embolization only, but it's actually in the middle between the two. So it's actually about 70% for embolization only. And then it dropped down to 29% at 3 years and 17% for controls. So it's showing then that chemoembolization is effective on this patient to treat unresectable HCC. This study showed the radiofrequency ablation, or RFA. That would be another option. With or without TACE, or transarterial chemoembolization, in the treatment of hepatocellular carcinoma, that they cannot actually get resection. And you can see there's 2 graphs, one overall survival, and the other one is recurrence-free survival. And obviously, radiofrequency ablation with TACE shown to be more effective in terms of survival and recurrence-free survival compared to radiofrequency ablation. And these actually were in tumors less than 7 centimeters. What about radioembolization with yttrium-90? These are microspheres that you can inject into the hepatic artery, and they get trapped in the precapillary system, and therefore send or emit radiation, high dose of radiation to the tumor. So you actually preserve the rest of the parenchyma and cause no damage to the rest of the parenchyma. But in general, what this study actually shown is that when you use yttrium-90, the time to progression and the overall survival was actually similar to chemoembolization. And what actually this study had done is, like, for the last couple of years, more and more people are using Y90 to treat patients with tumor, early or even intermediate tumors. That would be stage B. That actually led to this study, the premier study, that compared Y90 versus TACE in early and intermediate stage HCC. And you have on the left the overall survival, and on the right the time to progression. That was actually the main endpoint of the study. And you can see that the time to progression with Y90 was more than 26 months compared to TACE that was 6.8 months only. The median survival, actually, there was no statistically significant difference, so you can see to the left. But what is striking is that the time to progression is so different. And what we've done actually in our center, we're actually using more and more Y90 with good results, and actually less amount of patients with recurrence of HCC even post-transplant. So in terms of the patients that are optimal candidate for RT, that would be RFA that would be microwave, that would be standard of care for early stage HCC in patients that are no surgical candidate. The alternative to surgery, actually, for early tumors, less than or equal than 2 centimeters. And you can combine with TACE for single intermediate tumors about 3 to 7 centimeters. TACE is actually the standard of care for intermediate stage HCC and obviously preserved liver function. And most of the stages, they have preserved liver function except for the last stage, D. And then Y90, there were negative trials in advanced HCC, but it looks like based on the trials, the premier studies and everything, that you can use it for early and intermediate tumors and select a patient with large HCC and or PVT, portal vein thrombosis. For the research actually needed in terms of early intermediate care, intermediate stage, but we know based on some of the data and some of the centers actually data that actually Y90 is working pretty good for those patients. What about advanced stage HCC? It's a little bit more complicated. You have the systemic therapy for those patients, and we have the first line, that would be sorafenib, and then lenvatinib, and then you have the second line therapies, regorafenib, cabozantinib, and then ramucirumab. So the survival in these patients is about a year, as you can see, for first line therapy, and it's about 8 to 10 months for second line therapy. So we look at the studies for this therapy. The SHARP study was the first one back in 2008, and it was published in New England. Sorafenib is actually multi-kinase inhibitors for the vascular endothelial growth factor receptor. And look at the left end table or graph is the survival of these patients, and the one on the right is the time to radiologic progression. And what it shows actually that in both cases, survival and the time to progression, the sorafenib increase or make about 3 months longer the survival of this patient and the time to radiologic progression. So it means that these 3 months makes a big difference in this patient, more a patient that is dying with cancer, and therefore the medication was approved back then for as a first line for this patient as a systemic therapy. All right, so this is actually some of the side effects of the medication, hand, foot, skin reactions. And in that table, I'll tell you some of the intervention that you can use on those patients. Diarrhea, fatigue are also some of the side effects, and you can actually use dose modification or interruption depending on the patient and depending on how severe these side effects are. In terms of the first line, we also had lenvatinib, and that was actually approved last year in August. Based on the reflex trial, you can see was actually compared to sorafenib in a non-inferiority trial, and they have 954 patients randomly assigned to both medications, And the median survival for lenvatinib was 13.6 months compared to about 12.3 months for sorafenib. Therefore, the medication was approved also as a first line for patients with advanced HCC. This is the resource trial, and this is actually for regorafenib. Regorafenib actually was a trial for patients already been on sorafenib. They failed sorafenib, so they actually did this randomized double-blind placebo-controlled phase 3 study. And what they found was that the median survival for those patients on the medication was 10.6 months compared to placebo that was about 7.8 months. So that also led to the approval of this medication as a second line for patients with advanced HCC. The next study was a celestial trial, and that was for cabozantinib. And this inhibits the thyroid kinase, and is also approved for second line. And you can see here the overall survival in patients. It was 10.2 months for cabozantinib, and it was actually only 8 months for placebo, and also led the approval of the medication as a second line. The third one was ramucirumab. It's an antibody against VEGF receptor 2. It's a REACH-2 trial. And this actually was done in patients that have alpha-fetoprotein more than 400 only. And they found that the median survival was 8.5 months on the medication versus actually only 7.3 months in placebo. Pretty close, but also led to the approval in patients that have alpha-fetoprotein more than 400. There's two other medications, nivolumab and pembrolizumab, that actually have approval, FDA conditional approval based on phase 1 and 2 trials. You can see here, we're awaiting actually the result of the phase 3 for nivolumab, but actually the next drug, pembrolizumab, is actually dead. So the press release that was actually probably about a couple months ago, I think it was 3 months ago, showed that they did not achieve the end point on the phase 3 trial, so that one is dead. So in terms of terminal stage HCC, we know that would be best supportive care. These patients have only probably 3 months survival, and that would be probably hospice. That would be probably the option for those patients are, only 3 months of survival. So in summary, the burden of HCC is increasing and maybe increasing more with fatty liver. We don't know. We've seen actually is, I don't know, some of you guys have seen patients with NAFL, non-cirrhotic with cancer. Well, we see more of that patients. Screen your patients at risk, okay, with cirrhosis for HCC with ultrasound and alpha-fetoprotein every 6 months for early detection. Early stage HCC, that would be BCLC-A, may be cured with thermal resection or liver transplant. Intermediate stage HCC, that would be stage B, palliated with TACE or Y90. And actually, we're using more Y90 now than even TACE. Local measures often fail tumors with aggressive biology, and that's another difference. Sometimes these tumors actually behave differently, depending on the biology. Advanced stage, that would be C, palliative with some of the first line or second line therapies. Application therapy may be limited depending on the severity of cirrhosis, decompensation, or performance status of the patient. And more important, multidisciplinary teams are important for the outcomes of this patient. Your nurse practitioner, your PA, your oncologist, your IR doctors, all of these people are important to actually make the best approach for your patient with HCC. And obviously surveillance is key on these patients. So please, don't forget doing ultrasound every 6 months on those patients. Thank you.
Okay, well, thank you very much, Roberto, for a very nice overview of a complicated topic. We have some questions here that we're going to run through, and if anybody else would like to come to a microphone to ask any further questions. One of the things I want to ask you is clearly we don't biopsy patients to diagnose hepatocellular carcinoma, but in terms of some of the predictors of recurrence, particularly after resection or liver transplant, there is evidence that you can predict it to a certain extent. So do you anticipate, as we become more sophisticated managing these patients, we may actually opt to biopsy some of them at least to plan the appropriate therapy?
Yeah, and I think the problem with some of the patients is they have HCC and cholangiocarcinoma at the same time, for example. Some of these patients, the biology is different, and there's some markers now, even in clinical trials, that shown that some of those markers can tell you the patient will have a worse prognosis compared to other patients. So I think the biopsy, it depends. It depends on what the radiologist is seeing and CT scan on the MRI. Are they confident what they're seeing, and depend on the stage. It's a different stages system that is used for HCC. And they can tell you this is a high probability it's going to be HCC or it's not. And then you can decide, if you probably need to do a biopsy in those patients and how beneficial is going to be that biopsy for future and for transplantation. But
Okay, thank you. Another question directed to me is, do you recommend screening for fatty liver, and which patients would you screen? And I think all of us see patients who have an ultrasound done for a non-liver indication and are noted to have fatty liver. And so obviously, you're then presented with an abnormal imaging study and what to do about it. But the question is the corollary of that. If somebody, for instance, has diabetes type 2 or a high BMI, is it appropriate to screen them for fatty liver radiologically? And I think in our current state of knowledge, I think if they have normal liver tests, I don't think we need to increase the work of the radiologists yet more by sending these patients for imaging. So I think the trigger should be the presence of biochemical dysfunction. Roberto?
yeah, I think once you see patients that have AST elevation, usually more than 50, you have to start considering that patient probably have advanced disease. And that's been shown in studies before. So any patient that have AST elevation, think about progression of the disease and maybe, even do a fiber scan or biopsy.
Okay, thank you. Question, Roberto, I'll have you put on your transplant hepatology hat for a moment. The question is alcoholism still a contraindication in liver transplant in patients with acute liver failure who can't wait the 6-month sobriety?
Yeah, if you're considering patients that have HCC and alcohol, it's a difficult one. So it depends on the center. So we have, every center have to sit down with a multidisciplinary team and decide, what are the risks of this patient drinking? What are the risks the patient is going to progress this tumor, on the list? If you think the patient can be listed, and then you can use some liver-direct therapy in the meantime to buy some time, maybe you can do that. It depends on the exemption now points. And that may change it now too with units, but that's something that you have to consider. But I think if the patient is probably low to intermediate probability of drinking, I will probably go ahead and consider transplantation.
Yeah, and I think the pendulum is swinging back towards being more accommodating because a lot of these patients we see are young patients with severe alcoholic hepatitis. They don't improve with steroids, and they're not going to make it unless they get a liver transplant. The problem is we're not terribly good at predicting which patients are going to start drinking afterwards. But again, there is a movement, particularly in Europe, to facilitate transplant at least some of those patients rather than having them undergo the trial by fire of 6 months sobriety. This is a question for me about patients who are not obviously overweight, but still have evidence of fatty liver disease. And this is a pretty common conundrum. It's often in fairly young males, and clearly there's a lot of things we don't understand about this disorder. But in a patient like that, what I would do is look for all the obvious precipitants, including insulin resistance, hyperlipidemia, and so on. And what I do is just encourage them to pick up the exercise and limit carbohydrates. Roberto, would you like to comment?
Well, something that you have to consider, do those patients have any genetic disease? You can do lysosomal testing or any other, like if the patient have LDL and cholesterol is really low, is there anything else going on with this patient causing the fatty liver? And I've seen a few patients with genetic diseases so far. They're, non-obese with 90% fatty liver in the biopsy. So,
Okay, another question for me is how accurate are FiberSure, FiberTest, and I think all of these tests have a pretty good negative predictive value. If they're unequivocally normal, it's unlikely the patient has extensive fibrosis. But I think with all of this, it's important to take all the clinical clues like platelet count, physical findings, and so on, to try and arrive at a decision about whether the patient has significant liver disease or not. I think the test we rely most on non-invasively is the fibro scan. But again, there can be a discrepancy. And as I mentioned earlier, our major indication for biopsying these patients, if the non-invasive tests don't make sense, there's a discrepancy. So again, I think use all the clinical clues when you're evaluating an individual patient with non-alcoholic fatty liver disease.
yeah, so we have done studies at UF using the markers versus FibroScan, and the FibroScan is way far, better than the markers. And I've seen patients with markers showing cirrhosis when I do biopsy. There's nothing, completely normal. So, so I would probably consider strongly FibroScan. And more, when you had a FibroScan with, a levels of 7, for example, 7.4 or less, the positive predictive value is pretty high in those patients. So you know that probably the patient is okay. They don't have, they don't have any fibrosis. Those patients that have high scores, 12, 13, 14, then you have to be careful. If the clinic, your clinical, picture is a low platelet, big spleen, then the patient is probably cirrhotic. But if not, then you have to consider probably biopsy, to see the patient have fibrosis 3, fibrosis 4, and maybe consider for a clinical trial. So.
Okay, one of the other questions that came up in the breakout at lunchtime, which agents need to be discontinued in patients with fatty liver disease? And again, very common scenario, I think, for all of us is a patient seeing a cardiologist and they have been on a statin or they're going to get started on a statin, and whether it's safe to treat those patients with these agents. And I think the answer is unequivocally yes, it is safe. Intuitively, you're treating one of the precipitants, which is hyperlipidemia. And I think one of the clinical observations is if a patient with hyperlipidemia already has some hepatic dysfunction, starting one of these agents, it can get transiently worse. But I wouldn't back off in treatment unless you really had a major rise in the liver chemistries. Now, the problem is if you look at the PDR, every drug in there is implicated in hepatotoxicity. LiverTox, which is a website maintained by the NIH, is much more useful because it puts all these reports in context, describes the pattern, the likelihood, and the appropriate course of action. But again, I think certainly most hepatologists are very comfortable using statin agents in patients with fatty liver. Roberto?
Yeah, actually, when you go to the LiverTox website for NIH, the chances of getting any complication with statins is almost zero. If you look at how many reports, there's probably just a few. Very, 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 almost zero, really, honestly. And I put all my patients on statins. I mean, the benefits outweigh the risk on these patients with fatty liver disease and cardiovascular problems. So.
Okay, any other questions?
Maria and I will talk about a potpourri of IBD, so to speak. My job is to try and help translate clinical trials and the clinical guidelines into how we're going to do clinical practice and make some of the challenging choices. We had a nice discussion in the morning session about trying to decide between some of the therapeutic options, and we're going to continue along those lines. So let's begin with a couple of premises that I think are very important as we consider the treatment of ulcerative colitis and Crohn's disease. The first is, and we discussed this a bit this morning, that both Crohn's and ulcerative colitis are progressive. Crohn's disease leading to transmural complications, strictures and fistula over time. Ulcerative colitis can lead to a stiffening of the colon, but as we're aware, chronic inflammation leading to colon cancer. The second really important thing that we've realized over the past several decades is that the symptoms do not really reflect the inflammatory burden. Before we had some of these more highly effective therapies, I used to say that the treatment of Crohn's disease was the treatment of symptoms. And when we did it that way, the patients felt better, but we really did not change the long-term history of the disease, and patients went on to need surgeries and hospitalizations. The corollary to that is when we treat to deeper endpoints, to biologic endpoints, to resolution of biomarkers, as well, first and foremost, symptom control, but then controlling biomarkers and ultimately mucosal healing, and eventually this is going to translate into histologic healing in the setting of ulcerative colitis, we improve the outcomes even further. I also mentioned this morning that we really need to get the most out of our first-line therapies. Maria and I, in our practices, we are seeing day after day patients referred after failing 3 different types of biologic therapies. And for the most part, those individuals have a snowball's chance in heck of really getting better. And often it's more useful to operate on those patients and try and start with a fresh set of anastomotic sides. And then what we're learning further, and I'm not going to discuss this as much today, but pharmacokinetics and pharmacodynamics and therapeutic drug monitoring are really a way that we can improve the efficacy and the effectiveness of these drugs on a long-term basis. But we've learned how to do it reactively. We need to still learn how to do this proactively. So both the American Gastro Association and the American College of Gastroenterology have put forth different types of guidelines to the treatment of IBD. And since the last iteration of these guidelines, there have really been some changes along the lines that I mentioned in the first slide. We are now redefining what disease severity is and what disease activity is. We used to, well, for instance, the drugs are, the biologics are indicated for moderate to severe Crohn's disease, not responding, et cetera. Well, what does moderate to severe disease mean? Well, it actually means that the patients were having the symptoms that correlated with moderate severity on the Crohn's disease activity index. But what it doesn't imply is the prognosis of the individuals. We can have patients who have a lot of symptoms and a good prognosis, and vice versa. Patients who have more subtle symptoms, but by nature of their mucosal, the damage that they already have, a worse prognosis. So in both ulcerative colitis and Crohn's disease, both of the guidances say that we first and foremost assess the risk, the severity according to the risk of outcomes. In ulcerative colitis, it's the risk of colectomy. Crohn's disease, the risk of surgery in that situation. So I guess surgery in both situations. And I used to say that the risk was kind of like the Supreme Court definition of pornography, hard to define, but you know it when you see it. Well, it's the same with these risks. Patients who have limited disease, shallow ulcers, have a good prognosis, but I would emphasize in both Crohn's and in ulcerative colitis, deep ulcers are really one of the most important factors that I consider as having a bad prognosis in both diseases. Less likely to respond to first-line therapies, needing more aggressive and/or combination therapies. So the moderate to severe disease are these individuals who are considered to be at high risk of progression. And I guess along with deep ulcers, the requisite of steroids in either disease state is automatically going to be putting patients into a moderate disease category. We know that in both ulcerative colitis and Crohn's, once a patient starts on steroids, they have a bad prognosis. In ulcerative colitis, 80% of patients require ongoing therapy, and likewise in Crohn's disease, 40% of patients who start on steroids end up going to surgery within the first year. and another 40%, maybe again 80% total, become steroid dependent. So we should be thinking, as I said earlier, this is a chess game. As soon as we make a move towards steroids, we better be thinking, what are we going to be doing next to get them off steroids? And in both ulcerative colitis and Crohn's, mesalamine may not be the answer to that. So we can put in a number of other factors, but for the most part, it's pretty intuitive. The sicker the patient is and the more extensive disease that they have, the more likely that they're going to progress. And this applies both to ulcerative colitis and in Crohn's disease. And hence the pathways divide these patients into low risk and high risk for both ulcerative colitis and in Crohn's disease. Now, in ulcerative colitis, induction for low risk and maintenance is usually with a mesalamine. We may add in a topical corticosteroid for those individuals. And then once they respond, they move into maintenance therapy with mesalamine. However, if they don't respond, then they're instantly put into a higher risk category requiring more aggressive treatment, in particular if they require systemic steroids, as I mentioned, then they're going to be in that high-risk category. High risk in ulcerative colitis, as I'm going to show you, we have several different options that overlap greatly now in both ulcerative colitis and in Crohn's disease. So for these individuals at a high risk, the AGA advocates a short course of steroids, but with the initiation of a thiopurine. In ulcerative colitis, mesalamine after steroids may be effective, but it turns out that thiopurines actually have been tested and compared to mesalamine and actually are more effective. If the patients respond, we taper the steroids and maintain on the thiopurine, and of course then if they flare, then they're set up for biologic therapy. A second option, and by the way, although these are listed, they're not prioritized by the AGA. We don't have sufficient comparative effectiveness studies between any of these therapies in order to really prioritize which is first, second, third, etc. Another option is a TNF inhibitor with or without a thiopurine. And then again, I'm not going to get into it, but the controversies of what do we do with patients on combination therapy long term. Perhaps we can address those in the question. Third option is vedolizumab with or without an immunomodulator. And then again, continuing usually the vedolizumab. And frankly, in my view, once you're getting to vedolizumab, and in the near future, you'll also have ustekinumab, Stelara, available for ulcerative colitis. The great benefits of these drugs are their safety. When you're adding an immunomodulator, perhaps we're compromising that safety a little bit. So we want to get back onto that a safe route for individuals. And then what I don't have on this listed, but we certainly should consider, I forgot to modify the slide, is tofacitinib. And tofacitinib is given without an immunomodulator. It is interesting, in rheumatoid arthritis, it's administered with methotrexate safely, but particularly because we're using higher doses, up to 10 milligrams, and I'll talk about this in a little bit, twice daily, the risk-benefit of any additional immunosuppressive hasn't been assessed for that. Okay, there's my tofacitinib, finally. Okay. So in Crohn's disease, we also tried to divide between low and high risk. The problem is we really don't have any good evidence for the low-risk patients. The trials have all been focused on the moderate to severe disease not responding to conventional agents, and I'll speak to in a minute on mesalamine in the setting of Crohn's disease. None of the organizations are advocating mesalamine for Crohn's, and I guess I'll ask in a minute. But what we do have is budesonide, but only short term. Budesonide has been effective over 8 weeks compared to antibiotics, compared to mesalamine, and comparable to prednisone over 8 weeks. The difficulty is we don't really have any strong maintenance data with budesonide over a long period of time. Below 6 milligrams seems to be a cutoff for steroid effects, but really to maintain Crohn's disease, you need a dose somewhere between 6 and 9 milligrams daily. So you're tipping into the steroid effect on a longer term basis. And then for the moderate to severe, it's basically very similar to what we see with ulcerative colitis, steroids with or without an immunosuppressive, anti-TNF with or without, vedolizumab with or without. There is an option of using methotrexate instead of a thiopurine in Crohn's disease. I need to remind you, it's just like aspirin. 81 milligrams of aspirin has cardioprotective effects, but it's not very good for arthritic pain. The same thing with same kind of situation with methotrexate. 25 milligrams parenterally to wean off of steroids has been the effective dose, and 15 milligrams parenterally to sustain that remission. In contrast, when we're using methotrexate as to reduce anti-drug antibodies, we don't need quite as high a dose, and it can be given orally, as we've learned from our rheumatologic colleagues. I want to skip this. So the next concept that we, again, discussed this morning, but is very important with both ulcerative colitis and in Crohn's disease, is the concept of treating to targets. This has been derived from hypertension, blood pressure, rheumatoid arthritis, where picking a specific target, such as hemoglobin A1C in the setting of diabetes, actually has been shown to reduce long-term complications. So we're looking for targets, and there are a variety of different targets. I said earlier that if you treat to symptom control, the patients feel better, their quality of life improves, but it doesn't change the long-term course. The deeper we get into a remission, eliminating biologic factors, getting the bowel to heal if we can, all imply that the prognosis is going to be better for those individuals. And we no longer, if you had a patient that you're starting on an antihypertensive, you're not going to start them on an ACE inhibitor and say, go home and we'll see you next year, right? You're going to have them recheck along the way. So this treat to target concept includes this iterative process. Starting something, assessing its effect at whatever level or levels you want to do, adjusting therapy, reassessing along the way. I also emphasize that we always can't get what we want. Everyone is in tune with the concept of mucosal healing. It's much more accessible to us in ulcerative colitis than it is in Crohn's disease. And the deeper the ulcers, particularly in Crohn's, the less likely we are to actually be able to achieve this. So in rheumatoid arthritis, where they've been looking at this treat to target concept, rheumatologists are not so, the endpoints are not that different than us conceptually. If they have a patient who already has joint damage, narrowing and erosions, there's no drug that fixes it. You can't get the fingers to straighten up, but what you can do is reduce the inflammation around it. In the setting of Crohn's disease, we do not have any therapies that affect fibrotic strictures, but we can treat the inflammation around it. So our first goal in early disease, which is kind of superficial disease, superficial inflammation, is to get it to heal. But if we can't get it to heal, we're trying to get the inflammation around it to heal as best as we can. Now, let me delve a little bit more into detail regarding these different therapies. The first is mesalamine, 5-ASA agents. How many of you are using 5-ASA in the setting of Crohn's disease? Just raise your hand for me. So you're afraid to admit it, but I can tell you, looking at the patients going into the clinical trial, nearly half of patients entering into trials around the world are on mesalamine. So we've told you not to do it, but we're doing it anyway because it does work in some patients. And we just have to figure out which they were. I can tell you who they're not in a moment. But it's a little bit ironic that the older studies, the National Cooperative Crohn's Disease Study, found sulfasalazine. Anyone know what that is anymore? It's a mesalamine linked to sulfapyridine, was effective in treating the symptoms of moderate Crohn's disease. The studies didn't look at healing in that situation. But then subsequently, there are a number of controlled trials with the mesalamine agents, and it's been very challenging to actually demonstrate a substantial difference. And part of it is trial design, I will tell you. Nevertheless, I think there have been good studies to tell us when not to use mesalamine, and that's after corticosteroids. Here's a group of patients put into remission with prednisone with Crohn's disease, randomized to mesalamine 4 grams or placebo, and clearly no difference at the end of the year between these therapies. So once a patient requires steroids, mesalamine is not going to be effective. But it also tells you that about 20 to 30% of patients with milder Crohn's disease may do well on nothing in that situation. And that may account for some of this placebo response that we actually see. So we question, and I put this question for Marie and I because we seem to have a similar practice, but if we're going to look at it as being effective, and if it does control symptoms, we're now at an era where we're confirming it with either biomarkers or repeat endoscopy to show that we're really achieving the target that we want. There has been some evidence in postoperative Crohn's disease, but I will tell you it's not very strong evidence in that situation. And again, if you're going to use it, confirm the benefit. And it is not FDA approved for Crohn's disease in the United States, but interestingly, in other environments, it actually has been approved. And one of the reasons that we haven't seen it is that all of the studies with the biologics, infliximab or adalimumab, patients receive an open-label dose, and then the responders are randomized to continue on therapy with the drug or placebo. It's known as a randomized responder type of trial. It's what we do in practice. We give patients a drug, and if it works, we continue it. In the trials, we compare it. Well, there have not been any randomized responder trials with mesalamine. They were all treat-through trials. And the one setting where we've had a treat-through trial with a biologic agent in Crohn's disease was with certolizumab, and the trial failed. It didn't work compared to placebo long-term, just treating through versus placebo. When they switched it back to a randomized responder design, that's where they demonstrated the efficacy. So we're still missing this data. There is a trial in Canada that I think is going to be very important. In Canada, they're looking at a whole cohort across centers of patients on mesalamine, and they're doing the smart thing. They're randomizing them off. So half of the patients will stay on, the other half will stay off, and I think that'll give us a clearer view of this. Now, I also want to talk about immunomodulators briefly. This is azathioprine, 6-mercaptopurine. I'm going to focus on the thiopurines. There have been some consistent effects, about 40% efficacy in steroid sparing, whether it's Crohn's or ulcerative colitis. In Crohn's disease, there's evidence of reducing the risk of postoperative recurrence. It's reduced even further if an antibiotic such as metronidazole is added with that. We obviously have more experience now in combining thiopurines or methotrexate with biologic agents, and as a single agent, it's a cost-effective option. But the problem is it's not an inductive agent. There's no data that thiopurines induce remission. They sustain steroid-induced remission. They reduce anti-drug antibodies, that's what ADA. They have been relatively safe, but they have some baggage, of course, and that baggage is about 20% of people don't tolerate it. They get nauseated or they have body aches, and they just don't tolerate the drug. That's not the allergy that we're all aware of. That's not the pancreatitis allergy, which is a much smaller percentage of individuals, but this long-term risk of neoplasia. Skin cancers as well as lymphomas have really moved a lot of individuals away from this very effective, option for this. What we've learned about thioguanines, and this is about the thiopurines, azathioprine and mercaptopurine, is that the evidence base really does not make clinical sense. All of you know that there's an enzyme, thiopurine methyltransferase, that determines the metabolism of azathioprine or mercaptopurine to the final endpoint, which is thioguanine nucleotides. This is the effective endpoint of this, or the effective metabolite. The problem is if the evidence that's been done in controlled trials is testing 2.5 milligrams per kilogram versus placebo in those situations. And yes, 2.5 milligram per kilogram is effective, so it's evidence-based, but that's not optimal. Maria and others have demonstrated that the optimal dose is actually the dose that achieves an adequate concentration of the 6-thioguanine nucleotides. So I think it's pretty nonsensical to treat in a milligram per kilogram manner with these, and we should be adjusting the dose according to optimal thioguanine levels. Now, anti-TNF agents. We've learned a lot about the TNF agents. These are not new. Biologics aren't new. We're well beyond. We're into our 21st anniversary of infliximab's approval. And you're all aware that there are now biosimilars evolving for infliximab and eventually for adalimumab and the others. What we've learned about these is that they are effective. They are all immunogenic. It just depends. You can make the same drug more or less immunogenic. You can make infliximab. If you give a low dose of infliximab, 60% of people will develop anti-drug antibodies. If you give high-dose induction and maintenance, you reduce it to 13%. And if you do high-dose induction and maintenance and add an immunomodulator, you drive it to 6%. Same drug, different immunogenicity. So we need to be aware of how the pharmacokinetics can actually impact that. We've also learned that we didn't expect it, that combination therapy is more efficacious than monotherapy. And this is just a really good example of how post hoc data, how retrospective data are not the truth. They are hypothesis generating. We've seen this time and time and time again. So all these data, these series from pharmaceutical series and database assessments and such, they're very useful to plan prospective studies, but we can't rely on them as being actually the truth. In all of the studies with every single biologic agent, patients treated with thiopurine had slightly higher drug levels, slightly lower amounts of anti-drug antibodies, but no clinical differences, because the trials were not randomized according to immunomodulators or powered to show a difference. It's not until you flip it around and ask the question prospectively, in patients who have never received these, are they more effective in combination? And of course, we've learned that with the SONIC study in Crohn's disease, comparing infliximab, azathioprine, and the combination, and similarly also in ulcerative colitis. So I'm going to just skip through a couple of these things and add on to kind of go to the end of this. So I've talked a lot about the different therapies that have been available. And Maria, I'm just going to show you a couple slides. Maria was talking this morning that she didn't think ustekinumab or vedolizumab may work as fast. Well, when we started to analyze the data, this is similar to what we did with tofacitinib, looking at the diaries in the beginning of the therapy. You can see a clinical difference in bowel frequency, abdominal pain, and general well-being in the patients within the first 3 days after an infusion of ustekinumab. These are double-blind, randomized diary assessments with them. So I'm just going to skip to the very end because this does get very bit confusing. I would say that in particular in Crohn's disease, we really have two places where we can effectively change the course of the disease. That's early on, before there's structural damage, and secondly, after surgery, where we're really starting anew with clean margins. The problem is that's not where we've been inserting it. We've been inserting it in patients who have failed other therapies, those who already have complications that we're trying to prevent, and that's why 50% of patients starting on a TNF inhibitor within a year are off within that same year. Too little, too late, not doing effective therapeutic monitoring with them. And so once they have these structural damages, we really have very little potential benefit from these. So how do we decide amongst all these therapies? I'm just going to go to the last slide because there are a lot of different ways that we do this. This composite is what we call shared decision making. We sit down with the patient, we talk about their risks, their status at the present time, what their future is going to look like, what are their different therapeutic options, how sick they are at that time, how quickly they have to get better, what is their risk aversion. If they've got a brother with a lymphoma, try and get them to take a TNF inhibitor. Just not likely to be accepted. So we need to consider this long list. We do our shared decision making, and then I'd say it gets corrupted by third-party insurance. We go through 45 minutes of a discussion with our patient. We decide what we want. We send them home. We put in the application for the authorization, and nurses are all shaking their heads here, and then it gets denied. And then it's a matter of calling the patient. Well, we can try and get a peer-to-peer. It's getting excessive with this. It's really too time-consuming. But we do a peer-to-peer. It ends up accepted, rejected, whatever. Then you call the patient back. We want to talk about, oh, but you said this other drug was bad. Well, this is what your insurance company is doing. So we really are getting corrupted by that. But there is a rationale to doing it. This is kind of tough too. This is like the Supreme Court definition of pornography, of picking one of these drugs with the agents. You've got to go through the whole holistic with the patients and then decide on the therapy. But when you do, you make that first drug work first. Do everything we can to optimize it. If it's a thiopurine, it's to thioguanine levels. If it's a TNF inhibitor, perhaps it's treating to drug levels and/or mucosal targets. So with that, bit of a hodgepodge, I'm going to let your favorite Maria Abreu talk about some of the ins and outs of Crohn's disease, the outs being pregnancy, I guess. Outs?
Well, I think we both had sort of tricky talks, right? Because it's sort of like all of IBD. Could have been here all day to do it. So a few things, a few ground rules. I think we can put the lights up a little bit, but I'm looking at the slide people in the very back because I may need to just have you go to the last two slides if it's more important for me to stay on time. Will you be? Yeah. I guess I have a timer here because. We're gonna go. It's sort of like a potpourri of different topics. Obviously, we could spend all day talking about the complications of the disease or about side effects of medications. And I've chosen to do a little bit of both because really the reason for complications is either the complications of the disease or the complications of the treatment. An IBD, of course, is a systemic disease and can affect a lot of different organ systems. And I think as sort of a general platitude, I would say to you that medications in IBD, even though patients are always taking out of context whatever they've checked on Dr. Google, are much safer than the consequences of unfettered progressive ulcerative colitis and Crohn's disease, and all of the data that Steve has presented corroborate that statement. I actually read in the New York Times, where I get most of my medical information, that we have a 100% chance of dying of something. I don't know if you got that memo, and I apologize if I'm the first one to break that news to you. So there are a variety of different ways you could go. Lightning doesn't sound so bad sometimes. And you're lucky because in Florida, this is the state with the highest number of lightning-related deaths. Fun facts, and if you're playing Trivial Pursuit here. I don't like to think of the biking accidents because, I bike and I see a lot of these. I also don't want to think about drowning since I have to do a swim tomorrow. And actually, the closest I've ever come to drowning was at the last GALA. I decided after a long run to jump in the water right here across the street and was taken away by the current. Oh my God, it was so scary. But eventually I got to shore. Car accidents, like really, Paul and I have to drive on I-95 to go back. That's a very reasonable chance of dying. Cancer, heart disease. So you can see that we're all going to die of something. So all of those risks are going to be higher than the risk of all these different things happening to our patients with IBD, dying in a car accident. But you can see here that some of the things that do happen to our patients are the non-melanoma skin cancers. I think we discussed that a little bit in our breakout session. Influenza, zoster, pneumonia, VTE, and hepatitis B. And what's nice about having this in a box is that for most of these things, these are things that are preventable, and hopefully I'll impart how you do that. This is stolen from Miguel Reguero, who put together a talk on safety of IBD medications and sent it around to his IBD friends. And I decided to put an equal sign because I sort of view, and we'll show you the data, that ustekinumab and vedolizumab are both extremely safe, and so I didn't want you to have sort of a feeling that I was putting one over the other. But you can see, and I'll show you data, that in this context, safety is a little combo of infections and cancer. Although it's funny because hopefully we'll all be better communicators after the lunchtime talk, but do patients worry that much about infections compared to cancer? I mean, it's always about cancer, no? Is it? I mean, it's in fact, it's probably more likely that you could kill them with an infection, but in fact, they are more preoccupied with cancer. Okay. Okay, I'll skip that. Okay, so just a couple of slides on anemia and IBD. Anemia is very common. It's particularly common in hospitalized patients with IBD, and I often use the opportunity when they're in the hospital to give them IV iron unless they're so low that they need to get blood. This slide is to remind me that fatigue, what is such a common thing everyone complains about when they visit you is that they're fatigued. It is such an unbelievably common symptom of IBD. And yet we have become tachyphylaxed to the fact that most of our patients are anemic, and therefore, and we're used to dealing with GI bleeders, right? So like nothing really, shakes us up that much, like, 8, nah, I'm not going to scope them, right? I mean, in other words, that we become complacent sometimes with a significant iron deficiency anemia. And this, iron deficiency anemia is, of course, the most common reason our patients are anemic. Anemia of chronic disease is a close second and intimately linked with the fact that they have inflammation and therefore inappropriate erythropoiesis. And of course, vitamin B12 deficiency in the ileal Crohn's disease patients. What's sulfasalazine again, you said, Steve? Okay, I'm kidding. All right. A very compelling reason to try to make them iron replete is this. This is like you had me at hello. Maybe they'll stop calling. Do all your IBD patients call constantly, or now worse, email you through their portal, right? So who wants that? And so patients that are anemic are far more likely to call you. Go figure, because they're sicker, either you can think about all the reasons why. It's not that anemia is getting them to call you, yeah? Okay. And this is sort of all the reasons why they might be anemic. The obvious things, they're losing blood, they're not eating enough iron, but the last little bubble, I think, is an interesting concept, which is that patients that have active IBD, even if you gave them iron, they don't utilize, oral iron, I should say, they don't utilize it properly. It's sort of trapped in their epithelial cells and aren't getting into the bloodstream. I'll skip that because I think you know that. We use a lot of IV iron. I don't know if you do as well. Oral iron is poorly tolerated, but it's also that there's theoretical reasons that actually oral iron may actually not be good in IBD because it probably has very profound effects on the microbiome, not necessarily in a positive way. Iron is very required for pathogens to function correctly, and so therefore there's theoretical reasons why IV iron might actually be better. These are reasons absolute indications for IV iron. If their tank is extremely low and the hemoglobin is less than 10, it's very unlikely that you'll make them sufficient by giving them oral iron. Of course, we all know that we have to, in order to get insurance approval for IV iron, we often have to say that they have failed oral iron. We have all become sort of used to all the tricks of the game. The only point I want to make in this slide is that that many patients and doctors are sensitized to the fact, to sensitize is probably a good word, to dextran-containing preparations of iron that gave people anaphylactic reactions, and so that could be scary. But there are these dextran-free preparations of iron that are more expensive. You know, it'll require a prior authorization by someone, possibly your hematologist, possibly, you know, in our case, our hospital, to give them IV iron. And you can see that for iron sucrose, it's usually multiple doses, but you can there are protocolized ways that you could do it in 2 or 3 doses, so it's not as bad. And then this ferraheme and injectafur, which are the only ones that you can give them over 2 doses. Earlier today, I think it was in the breakouts, we discussed the fact that for some patients, you might want to put them on autopilot of getting IV iron every blank, every 6 months, it could be every 4 months, just to keep them replete. Okay, thromboembolic risk in IBD deserves, you know, its own talk, but I'll give you one slide. And this slide is to make a few points. First of all, what's not shown here is the fact that that this is much higher than, like, just, I guess people in the hospital are kind of sick anyway. But IBD is associated with an increased risk of having thromboembolism, and in fact, it's the reason that people die is having blood clots, right? And this could be as simple as they clot their PICC line. In fact, the University of Michigan has a nice study showing that in patients who have a PICC line and are getting TPN through their PICC line, they, you know, when they're sick from their IBD, they get a blood clot there. So in the hospital, they need to be on Lovenox or heparin. And what this slide says is that even when they leave the hospital, there's still this period of having them be hypercoagulable. Notice that if they're on biologics, which is the black the solid squares, let me see, does that work? Ooh, how cool are we? Does that, yeah. That if they're on biologics, which in theory, you know, has a more rapid effect, these are patients that can normalize more quickly and don't have this thromboembolic risk as much. You know, lymphomas, I mean, we can talk about solid tumors, but most of the, lung cancer, all these other cancers, most of the data now, and the most compelling is a very large meta-analysis by Jim Lewis showing that for all intents and purposes, there's not an increased risk of most solid tumors in patients that are on biologics, anti-TNFs. Really, when you think of lymphoma, it's the thiopurines, in my mind, that drive that risk. And in this cohort, the Sazame cohort done in France now for a couple of years ago, you can see that if the colors are continuing, the thiopurine discontinuing or never received. And you can see that when people are younger, less than 50 years of age, their overall risk of developing a lymphoma is low. And so it's increased a little bit by being on a thiopurine, but it's always tripling, about triple the risk. But if you have a very low risk, like a very low chance that you're going to win the lottery, buying 3 tickets to the lottery will not get you very far, right? However, unfortunately, as you get older, the risk of developing a lymphoma, because it's a garden variety kind of cancer, increases, and therefore, if you triple that risk, now we're getting into substantial numbers. And I use this as the basis for generally not beginning someone who's in their late 50s, early 60s de novo on a thiopurine, but having a thoughtful discussion with those patients that have been on it and are doing fabulously well about whether we should continue that, right? So it's an opportunity to have that discussion. This is an earlier study from the University of Pennsylvania. I think Corey Siegel was also involved in this study that looked at adalimumab and the risk of lymphoma, right? Because thiopurines, it's funny, I mean, I think it's being used less and less, even though they're still, you know, very good drugs. But the real issue is, what about anti-TNFs, right? We've had a lot of experience with anti-TNFs. Again, if you didn't get the memo, our patients are all being changed to the biosimilar of infliximab, and ultimately will be changed to the biosimilar of adalimumab before we know it. And so it's still going to be used a lot. And in this particular study, Mark Osterman did not see an increase in the risk of lymphoma compared to the SEER database, you know, matching people by age and so forth. And you can see that for monotherapy, the risk is it's not less than the normal population, but it's about the same as the normal population. Whereas if you add an immunomodulator to that mix, you increase the risk of them developing a lymphoma. Again, corroborating my thought that it's really the thiopurines that drive that risk. And then this is probably the biggest and best version of that study, and it's a busy slide, but it was the best I could do to try to simplify it. And in this, what this JAMA paper showed is that if you look at thiopurine monotherapy compared to nothing, basically no anti-TNFs and no thiopurines, the risk of developing a lymphoma is 2.3-fold. If you look at anti-TNF monotherapy compared to being on nothing, it's a little more than 1, although in my way of understanding statistics, it's still the confidence intervals cross 1. So I'm not, the authors say that it was significant, but it's not readily apparent that it's significant. And then finally, if patients are on combination therapy, the risk is the highest. So I think that what I imagine is happening immunologically and oncologically is a little bit of anti-TNF maybe does increase the risk of lymphoma, a very little bit. But if you combine that with a thiopurine, that really is accelerated. So it's another reason why we have adopted an idea of kind of being thoughtful about who needs combo and how long do they need it for. These things don't happen overnight. These things happen over time. And so it's also a matter of how long are you going to keep that person on the combo. The good news is once you stop the thiopurines, the risk diminishes. And so this is a study from the VA. And if you look at the fine print of the study, even within the first year off of the thiopurine, the cancer risk starts going down, or is back down to the average of the population. So stopping it will bring it back down. And I show this to you because I find it compelling to tell people, we're going to do it. We're going to do it for a finite period of time. It's a negotiable contract. It's not written on Moses' tablets. But in addition, when we stop it, no harm, no foul. We'll go back to having your baseline risk of having a lymphoma. Okay, I'm going to skip this one. Okay, infections and IBD. I didn't do a very good job, I'm going to warn you, about infections and IBD, because that could just be lists and lists and lists. TNF monotherapy does increase the risk of, I'm only focusing on serious infections, and serious infections has a definition. I think it means like you either die or you needed to be hospitalized. Is that true? I think that's the definition of serious infections, right? Not just that like, someone gave me a Z-Pack, which is a dime a dozen. And you can see that both TNF monotherapy and immunosuppressive therapy in general is associated with an increased risk of serious infections. In this particular study, which is Bill Sanborn has a really smart guy, Sid Singh, who every other day, I think, has a publication in the literature doing some kind of network meta-analysis or systemic review, and I don't know, right? Like maybe every other day? Okay, so what you can see here is that immunomodulators were actually associated with fewer infections if you're comparing them to TNF monotherapy. I'm not sure that's that useful because it's sort of different types of infections. People who are on immunomodulators tend to get viral reactivation, right? And whereas people who are on anti-TNFs tend to get more of the obvious tuberculosis, but also bacterial type infections. I'm going to tell you that okay, people need to stop, but here you go, 3% serious infections with people on anti-TNFs. And so I think here, again, I'll tell you, ironically, patients are more interested in having the discussion about cancer than they are about infections. I just let people know that if they get sick, they need to tell whoever's seeing them that they're on an anti-TNF. Since they don't take it as a daily pill, they'll often forget to tell the urgent care, because everyone goes to urgent cares now, right? If you cough or you have an ingrown toenail, they go to an urgent care, and they might miss that as part of the history. I'm going to show you the two slides, this one and the next one, are that Veto and ustekinumab are safe, okay? So these are data from the maintenance study done of ustekinumab. They now have 3-year data, and for all intents and purposes, at least with respect to infections, it looks like about as close to placebo. You can see 2.3% rate of serious infections in placebo, and the same rate for the dose of the ustekinumab that all of us are using. In this particular one, they didn't have deaths. You can see malignancies. There's really no signal. And interestingly, at least with respect to immunogenicity, actually ustekinumab, more than any of the other monoclonal antibodies, has the lowest rate of immunogenicity. And in terms of trough levels, when you combine it with a thiopurine, the thiopurine does not raise the levels of the ustekinumab any further, which highlights how so much of the levels, of trough levels, and the effect of the thiopurines is preventing some very low-level immunogenicity. For vedolizumab, again, this is just looking at serious infections. There's a very low rate of serious infections, although I do like to tell people that I've seen a couple of very serious pulmonary infections because there is some MADCAM in the bronchial epithelium, bronchial vascular epithelium, and so you shouldn't, if people are coming back to you with infections. I also recently had a case of an older woman develop respiratory syncytial virus and almost need to be intubated, who was on vedolizumab, and I'm changing her now to ustekinumab. So tofacitinib, I did want to tell you a couple of things about tofa. Steve already presented that tofacitinib is only approved for ulcerative colitis and really seemed not to have a benefit in Crohn's disease. You need to know it can cause a reactivation of herpes zoster, and so people need to be vaccinated. There's also a black box warning for lymphoma. It increases cholesterol levels, so you need to now be thinking about cholesterol. But I did feel that, and for now, we're not using it in pregnancy because there is no good data for its use in pregnancy. And, again, I'd like to not have my patient be the first one on the block to get that. This issue with the herpes zoster is an important one. We are vaccinating patients who are going to start on tofacitinib with Shingrix. The Shingrix vaccine is a completely recombinant vaccine. When you hear the word recombinant, this means that there's no possibility it can cause infection. It's not a attenuated virus, or there's no live virus involved, and therefore it can be used. In addition, it turns out that this particular zoster vaccine is a highly effective vaccine, one of the most effective vaccines ever developed anyway, period, for any disorder. So it's nice to know. The patients need to get 2 doses of it, preferably when they're not on being immunocompromised by something else, but you do what you can do, because for a lot of these patients, they're going from one biologic to tofa. This is from the infectious disease guidelines. How long do you have to wait to start immune suppression after a live virus, right? Because we're getting are you getting a call every 10 minutes about measles and what to do about the measles vaccine? Or, okay, we have a very biased population. So you have to wait at least 4 weeks after they get a live virus to start them on whatever you decided you're going to start them on. We don't give live influenza. It's actually not as good as the recombinant anyway. The MMR, unfortunately, which is the measles vaccine, is live. So if your patient is on a biologic, it's a moot point. You can hang up on them. They can't. No, you don't hang up on them. But because we're good communicators, we're being empathic, right? So, but we tell them that, we can't really vaccinate them, so it's not really worth checking titers. But their household contacts can be vaccinated. They just need to wash their hands and all of that because there is shedding in stool. But common things are common, and this is only to make the point that C. diff infection is so common. They don't need to have the routine risk factors. We find it all the time when we think, let's just check it just in case, and wouldn't you know that they have C. diff. That's particularly true in ulcerative colitis, where their microbiome is very disrupted, and so you should be thinking about checking C. diff every time they flare. Psychosocial effects of IBD, I think anyone who has more than 3 patients with IBD know that they're anxious and depressed, and therefore that merits its own treatment, I don't feel I'm the best at that, but I certainly think that a good primary care doctor can treat them. And the screening questions are pretty easy. Now it's incorporated in the EMR, and our nurses do the screening. Have you felt down, depressed, hopeless, basically like all of us. Over the past month, no, I'm kidding. Have you felt little interest or pleasure in doing things? Okay. Bone disease and IBD, I'm afraid, I hope no one has a seizure disorder because I know I'm going pretty fast. These are in your thingy, or can be in your thingy, and downloadable if you want. So bone disease is common. The normal guidelines for checking for osteoporosis, like, postmenopausal women and all that still apply. But if patients have been on more than 3 months consecutively of steroids, they deserve a bone density examination. This is a very old slide, but I came across and I wanted to make the point, not so much to sell you on using budesonide in people, but just to make the point of how rapidly, with the very first course of steroids, people lose bone mass, okay? And it's less so, of course, if they're on budesonide as choice of steroid. Again, it's only to make the point that really steroids have a profound effect on bone mineral density. Anti-TNFs flip that. Anti-TNFs, and possibly, but we don't know yet, any treatment for IBD that reverses the effects of IBD may have a similar profile, but bone synthesis is increased in patients who are on infliximab, and bone resorption is decreased in patients who are on infliximab. This is the study done in children, where this is, of course, particularly important for them to reach their full bone density. So screening, the only thing I want to tell you about on this slide is this last bullet point. It turns out to be super easy if you ever wanted to treat their osteoporosis. If they're getting biologics, a once a year zoledronic acid, which is commercially known as Reclast, is effective, and so you can consider that. All right, skin issues. New psoriasis after anti-TNF therapy, it's a dime a dozen. The better the patient is doing on the anti-TNFs, the longer they've been on it, their TNF is very neutralized. They start making unopposed interferon alpha, and these are the patients that develop the palmar-plantar pustulosis. These are the pictures of a couple examples. It can be painful. They can have a lot of pain walking on these, and incredibly and interestingly, many dermatologists still haven't gotten that memo that this is related to the anti-TNFs, right? And so they'll tell the patient, oh, well, we use, anti-TNFs to treat it. And you can imagine, well, if you use anti-TNFs to treat it, and they've gotten this form of psoriasis while on it, anti-TNFs are not only not going to swing it, are probably causally related. So the best treatment for this, I apologize. The best treatment for this is stopping the anti-TNF and going on to something else. Now, often we had thought that something else could be ustekinumab, and of course that's a natural choice for people who have Crohn's disease. But I just want to make the point that compared to ustekinumab, probably for generic psoriasis, garden variety psoriasis, this isn't as effective for the psoriasis. It's just a way to get them off the anti-TNF. Cancer screening, my colleague Dan Sussman will be following us and talking about colon cancer screening, but we like our patients to see dermatologists once a year, and cervical cancer screening for women. All right, this is pretty okay. I have 2 slides. So what should we do to minimize the risks in our patients? We do routine lab monitoring. We stratify risk. Older men on thiopurines are at a much higher risk than if they were young, young or middle-aged people. We vaccinate patients. They should get the seasonal flu shot. That's recombinant HPV. Now most young women are getting HPV vaccines. The 2 pneumococcal vaccines should be given in patients getting biologics, and Shingrix if you're starting on tofacitinib. We avoid live viruses vaccines if they're already on immunomodulators. And IV iron, if your patient is iron deficient, consider giving the bisphosphonates IV when you have an opportunity. And, vitamin D supplementation, most patients, even in South Florida, are vitamin D deficient. That's it, and B12 in patients with ileal Crohn's. And I thank you for your attention.
So our next speaker is, as we already heard from Maria, is Dr. Dan Sussman. He's also at the University of Miami, where he focuses on inherited colon cancer and other inherited cancers.
Afternoon, everybody. Thank you for having me here to speak. I'm just figuring this out here. Okay. Thank you for having me here today, and hopefully I'll try and keep you all awake as we're finishing up the sessions here. So as far as learning objectives for what we're going to go through today, one of the main points to recognize here is just that the epidemiology of colorectal cancer is shifting, and it's shifting in a way such that younger individuals are getting these incident colorectal cancers. I wanted to just touch on a few topics related to this, which is that we do have plenty of methods of screening for colorectal cancer available, but they do have their limitations in expanding them to the population as a whole. I want to just reinforce the point that recognizing the warning signs for colorectal cancer is one of the major ways in which GI doctors and primary care doctors can intervene to decrease mortality from colorectal cancer, and try and drive home the point here that taking a family history is tremendously important in preventing cancer for patients themselves and for their relatives, as well as making sure everyone here knows that genetic testing is widely available. So this is one of your standard maps of the world that everybody shows for epidemiology of disease, but I put it up here because it's one that's changed recently for colorectal cancer, and you'll notice that all of the countries that are dark blue and medium blue in color here are the best places in the world that you can go to get a steak, some cold cuts, or some lamb chops. Maybe Argentina, the United States, Australia, and Spain. And that's not by chance. It seems like there's a major role that both obesity and diet from red meats and processed meats in particular play in the role of colorectal cancer. So I'm going to start off here showing you some graphs as well, and I'm going to try to break them down to make them a little bit more digestible. But this is basically looking at colorectal cancer incidence by country. And the reason why this is important to look at every decade or so is so that the countries themselves can look at where they stand epidemiologically to see how they're doing with respect to certain cancer types. And what you can see here on this slide is in particular countries like Spain and Brazil, and even other countries where the standardized incidence rate of colorectal cancer is tremendously low, like Thailand or other Asian Pacific countries, really need to start paying attention to colorectal cancer as the incidence for these cancers are on the rise in those countries. Which brings us to kind of the crux of the talk today, which is that the American Cancer Society very recently made recommendations that colorectal cancer screening for all Americans should begin at the age of 45 instead of the age of 50 for average risk individuals. Just to make sure we're all on the same page here, average risk individual means somebody who does not have a family history of colorectal cancer, does not have a personal history of colon cancer or colon polyps, and has not recently had symptoms or warning signs that are concerning for a GI tract cancer. And so the ACS made these recommendations, dropping the age to 45 for the average risk individual. They also went a little bit further, saying that colorectal cancer screening should begin through the age of 75, and that it needs to be individualized between the ages of 76 and 85, and likely stopped after the age of 85. And we can talk a little bit more about the pluses and minuses of these recommendations in a moment. But over the coming slides here, I'd like to show you some of the data from which they made these conclusions, and show you some arguments for and against people who support these conclusions. So this is worrisome trends in colorectal cancer incidence. If I at first draw your attention to the line graph on the bottom of the screen, this is a feel-good story here in that for individuals who are over the age of 50, colorectal cancer incidence is on the decline for both men and women. And if you look at the inflection point on the graphs there, it looks like this decrease in colorectal cancer incidence began around 1980s. And if we all kind of think back and start scratching our heads, this is really a few years after we really started doing colorectal cancer screening in force, predominantly with colonoscopy-based modalities, because the tremendous decrease in arch of those lines there is actually in the early 1990s. And so colorectal cancer screening played a major role why incidence of colon cancer has dropped in this over 50 age group. On the other hand, in the under 50 age group, there's been an uptick in colorectal cancer incidence that's been noted since about the late 1990s, and it's really only been popularized and publicized recently because of the lag time of development of colorectal cancer. And so this begs the question, why is this happening? Many people have theories, some of which may be related to teenage obesity and just the obesity epidemic in general access to food products, especially those that are rich in red meats, processed red meats, and other risk factors for colon cancer. So what do we do about this? Well, the American Cancer Society said that we should be performing screening for everyone 45 and above, and where did they get that number from? So these are two really busy looking graphs, and I'll break them down for you in a very easy way. The graph on the left is the rate of colorectal cancer incidence per 100,000 individual, and the x-axis on that first graph is the year of birth. So if you look at each of those different colors being different 5-year segments, you can see that for each 5-year segment of individuals, for example, over 85, 80, 85, 75 to 80, that within each of those short 5-year lines, that the younger the individual, the less likely they are to get colorectal cancer. That ceases to be true once you get in the 50 to 54 year age group and below. So this means that below that 50 to 54 year threshold, it turns out that younger individuals within each cohort are getting colorectal cancer at a higher incidence rate. And why is that happening? So if we look to the line graph on the right-hand side, this is the rate of colorectal cancer incidence per 100,000 individuals based on the year of diagnosis. And really the important point to show you here is that the green line of 55 to 59 and the yellow-orangish line of 50 to 54 start to converge. And if you had looked at that 20 years ago, the rate of colorectal cancer in a 55 to 59-year-old was at least twice that of a 50 to 54-year-old, and that's no longer the case. And so this is why people in the American Cancer Society started talking about the age of 45 maybe as looking as a reasonable age to decrease the colorectal cancer incidence screening number. So is it the entire colorectum where this increase in incidence is occurring? And it turns out that in these super young individuals, it looks like it's actually the distal colon, distal colorectum, where most of these colorectal cancers are starting to be identified. The incidence rate on the graph here has gone up for distal colon cancer annually since 1994, and it's gone up tremendously for rectal cancers from 2.6 per 100,000 in 91 to 4.8 in 100,000 in 2012, and that's actually a tremendous increase. This is a slide showing similar data, but also breaking it down by racial groups. This slide shows that the high rate of rectal cancers is true not just for black individuals, but it's also true for white individuals. In fact, if you were to look back from the mid-1990s to the mid-2010s, if that's what you call them, it turns out that the rate of incidence of rectal cancer has increased so much so in white individuals that it's gone from being well below that of black individuals to being way higher than that of black individuals. Kind of the feel-good story of this slide, I guess, is that once somebody gets colorectal cancer, that there isn't any disparity anymore for black and white individuals in these age groups for their 5-year survival. So that's, I guess, a feel-good portion of this slide. But incident rates are increasing no matter whether you are white or black. And that's not just for rectum, but also for the distal colon. So you really can't make an increased screening recommendation to age 45 just based on looking at graphs of incidence. You have to do this based on some kind of data. And we don't have great randomized controlled trials comparing people starting screening at age 45 to people who started screening at age 50 to know what happened over the subsequent 20 years. And so in lieu of that, we do modeling studies. And just to kind of give you a little bit more background here on how those get performed, there's really brilliant individuals who write code for computers detailing formulas that mimic the observed incidence of colorectal cancer from large observational studies. And there's 3 large models that currently exist that formulate the CISNET model that everybody looks at for their societies to look at the incidence of colorectal cancer. And so what the American Cancer Society did is they used these very same CISNET models that all of our societies have used to make our recommendations to start screening at the age of 50 and input this new data that came from the SEER database and others. And once they put this new data in these models, what they found was that if they started screening at age 45 instead of age 50, so for each of these different colorectal cancer screening modalities, the blue line is 45 versus the red line, which is age 50 for the age to start, they found out that there was an acceptable gain in life years quality with every single one of these modalities when starting screening at age 45 instead of age 50. Now, you need to not only look at the life years gained, but you need to look at the potential of complications from colonoscopy for each of these additional procedures that are being performed. And specifically, they looked at the complications of perforation, bleeding, and death, most likely related to the sedation itself. And it seemed that the life years gained efficiency, which is comparing the life years gained to the complications from a colonoscopy, seemed to be acceptable for the majority of the modalities of testing that are on this slide here, especially with colonoscopy, flexible sigmoidoscopy, CT colonography, and high sensitivity fecal occult blood testing. As a little asterisk here, this study did not at all take into account any dollar signs, and we're going to talk about the meaning of that in a few moments here. And so the conclusion was from the American Cancer Society's perspective that based on those is that we should decrease the rate to 45 for average risk individuals, but it's with the corollary there that it's a qualified statement. Qualified, and this is a quote from the actual report itself, there's actually limited direct evidence of screening effectiveness in adults under the age of 50. That's because it's all observational studies, not RCTs as we had mentioned, and that the observational studies were little subgroup cohorts where the numbers weren't significant to actually show a benefit of screening in those individuals. So some real smart folks that represent many of our GI societies wrote an opinion paper that showed up in Gastroenterology, kind of breaking down the potential benefits and ill effects of screening everybody starting at 45 instead of 50. So the obvious is that you're going to screen more people, which is fantastic. You may even have the opportunity to decrease some disparities with colorectal cancer incidence by screening more ethnic and racial minorities, and that you might end up increasing screening rates overall for individuals. But there are some potential unintended consequences. One of them is we may be diverting our resources to a low-risk population, meaning that the very same people who are getting screened at age 50 anyway are going to end up getting screened multiple more times starting at age 45, perhaps without a great outcome. We may end up increasing our screening disparities because it's going to be the same individuals who have access to health care and are already getting screened. And there'll be an actual lost opportunity to actually study the effects of screening this younger population, and it may be at a tremendously increased cost to our society. But probably one of the most profound points to make from this is that if we do have a limited amount of resources to screen people for colorectal cancer, if we divert all of our attention to screening a younger group of individuals, perhaps we're going to be diverting attention from a much higher group of individuals, which would be older individuals who have yet to be screened. So if we look at this column with this bar graph here, you can see that on the far left, the age 45 to 49 group, the CRC incidence rate is far lower than it is for the other end of the spectrum, the age 65 to 74 groups. And many individuals are unscreened in that 65 to 74 age range. And so the argument for these individuals was that we should focus a lot of our attention, if we have limited resources, on screening these older unscreened individuals. It turns out, before I go on to the next slide here, that since I made this presentation and still yet to be published, is some of the individuals who wrote that opinion paper actually did a cost analysis of screening of individuals in that age 45 to 49, and they actually came to the conclusion that it probably is cost effective to screen in these younger individuals, as long as it's not at the expense of screening older individuals in our country, because the value that you get from a cost perspective in screening the older individuals is actually much higher. So along those lines, our U.S. Multi-Society Task Force and the U.S. Preventive Services Task Force still do recommend screening individuals at the age of 50 instead of the age of 45, so we have some conflicting recommendations from different societies. And the American Cancer Society publications did prompt great discussion in our literature. And the U.S. Multi-Society Task Force says that they appreciate the recommendation of the ACS. At the moment, they disagree with its official rollout, and that it's a great opportunity for increasing discussion and increasing study, particularly from a cost perspective. And perhaps the more recent study answers some of those questions about it being beneficial from a cost perspective. So how do we identify some of these younger individuals with colorectal cancer? So first of all, probably the most profound statement to make here is that there's certain symptoms that patients present to our clinics with that are worrisome for colorectal cancer. That would be hematochezia or unexplained iron deficiency anemia, or somebody who has melena with a negative upper endoscopy. And it turns out that these three predictive factors have a high yield in identifying individuals for colorectal cancer that are under the age of 50. We also need to take an adequate cancer history in the outpatient setting. And so for every individual that shows up in our GI clinic and every individual who shows up on our procedure table for an open access procedure, it's our duty and our responsibility to take a personal history of colon cancer and colon polyps, as well as a family history of colon cancer and other cancers, as well as family history of colon polyps and first-degree relatives, to try and figure out if there's some kind of a familial problem that's occurring there. Typically, taking a 3-generation history is considered adequate. We have to recognize that there's obviously limitations on people's times in an endoscopy unit, but certainly a bare minimum, you need to be asking people about a history of cancers in close relatives, not just colon cancers. The gold standard is actually drawing a pedigree for these individuals, and this is, again, a 3-generation pedigree that you can see in the lower right-hand corner of your slide. This happens to be a family with Lynch syndrome, where there's people affected across 3 generations, both man and woman, with people dying of young ages of Lynch syndrome-related cancers, including colon, endometrial, and perhaps even other GI tract cancers. And so recognizing that it's not feasible and it is time-consuming to do a full drawing of a 3-generation pedigree, there are easier ways and faster ways for you to do a rapid assessment of somebody's personal and family history of cancer when they're in front of you in the procedure area. And along the lines of how to identify people with these high-risk histories, certainly if there's anybody in the person's family who had colorectal cancer under the age of 50, that's considered a red flag for a concerning history. While we're on the topic here, if you do have an individual who is diagnosed with a colorectal cancer under the age of 50, all of their first-degree relatives, which means brothers and sisters and children, need to start having colonoscopy either at age 40 or 10 years younger than the youngest individual with colorectal cancer. And that's something that we frequently forget when we're seeing our patients. So how do we identify these individuals based on history? Well, so again, an age less than 50 is the most important item on this slide here. But also, if you find out that a particular individual has had multiple colorectal cancers, whether they be synchronous or metachronous, meaning at the same time or at different times, if a single individual has multiple different types of colorectal cancer, or if looking over a family history, you see multiple people with cancers, particularly with those at young ages. I do also want to point out here that it's not just performing colonoscopies on these individuals, which is the way by which we might tremendously impact the incidence of colorectal cancer and its mortality. But identifying families at high risk is important because we all have access to germline genetic testing. And so if you look at an individual and find that they're under 50 with colon cancer, or you look across their family and it looks like their family has some increased risk of cancer, this is somebody who should be referred for genetic counseling and probably genetic testing. And genetic testing is available in every state in the United States, and there's hundreds, if not thousands, of genetic counselors in each of these locations. Again, not only is it widely available, but it's easy to perform. In most cases, genetic testing is either just a blood draw or spitting in a cup or taking a buccal swab there in the clinic, so it's relatively easy to obtain, and it's actually very cost effective. 3 years ago or 4 years ago, had we been talking about this, I might have told you that it's several $1,000s to have genetic testing performed. Now it's about $250 for a list of genes rather than just a singular gene. What is the yield of performing genetic testing in the young individual with colorectal cancer? It turns out that about 16% of individuals under the age of 50 have a germline genetic mutation. Germline meaning that it was something that they were born with and is in every cell of their body. The most frequent GI tract related genes that are found on these panels include Lynch syndrome related genes, so that's the MLH1s and MSH2s that you see on the list on the right there. But there's also other unexpected findings that pop up on these panels, including some of the BRCA or breast ovarian cancer related genes that may not in and of themselves have a tremendous impact on the incidence of a colorectal cancer, but can certainly contribute to other tremendously prevalent cancers in the patient and in their family members. Early onset colorectal cancer is also a different beast. So if you do identify an individual that's under the age of 50 with colorectal cancer, they're much more likely to have synchronous colon cancers, meaning a second one at the time that you scope them. So if you do have an obstructing lesion at a colonoscopy, you need to make sure that that patient's full colon is visualized within a rapid period of time after their obstruction is alleviated. These patients are more likely to have molecular findings in their tumors called microsatellite instability that affects treatment and subsequent growth of further cancers and similar. For those individuals who are younger than 40 or even younger than the age of 30 with colorectal cancer, they're tremendously more likely to be identified with other genetic abnormalities, including those in the APC gene that have a tremendous impact in colorectal cancer incidence over time. Individuals under the age of 30 are also much more likely to have signet ring histologies, which are very poorly differentiated cancers that actually have bad outcomes. And that's why it's important to recognize warning signs in those individuals. I would also like to point out to you on this slide here that the American Cancer Society's recommendation to screen individuals from age 45 and up with average risk won't do anything to address the risk of colorectal cancer in people that are under the age of 45. And quite simply, that's because you can't go around doing colorectal cancer screening on every single person at the youngest ages that exist. So there'll be some debate in the literature going on at what is the optimal age to start. And this slide is here just to prove to you that the molecular findings in the colorectal cancers in these very young individuals with colorectal cancer are different than older individuals, meaning that they have a poorer prognosis based on some of the molecular findings that are displayed on the chart here. So it's probably not just the known gene abnormalities that are contributors to colorectal cancer in these early onset individuals. Clearly, there's some component of it that is obesity. We know that teenage obesity has a tremendous impact on future colorectal cancer risk. As I mentioned earlier, diet is a major player here. Diets rich in red meats, and in particular processed meats, have a tremendous impact on colorectal cancer incidence. For those who are wondering what a processed meat is, probably the best description of that actually came from an editorial that was written in the New York Times by a nutritionist. Basically, it's any piece of meat that might come from a deli counter at some point wrapped in plastic. So a cold cut, a bacon, a sausage, and that's the best way to think about it because it may even be the bird meats as well, including turkeys and chickens, when they're in cold cut formulation. And then clinician awareness is another big one here. I can't tell you how many people I see in my clinic that are under the age of 40 with colorectal cancer that have been telling people for 5 years that they have rectal bleeding when they go to an emergency room or a doctor, and nothing is done about it. So as far as some parting thoughts here for you, I just want you to recognize that there is, in fact, an increasing incidence in colorectal cancer in younger groups. It seems to be that it's more rectal cancer than anything else as far as a region of the colorectum. It's happening in all races and all ethnicities. Physicians and all healthcare providers need to be aware of the warning signs for colorectal cancer. So if a young person does come in with rectal bleeding, just have a higher level of suspicion than you may have had in the past. Every time we have an encounter with an individual in any clinical setting, it's actually our duty and our responsibility, and probably will soon be one of our quality measures, to make sure that we've documented a family cancer history in the chart, and that if we do identify individuals that are at increased risk based on personal or family history of cancer, recognize that it's not just performing early and more frequent colonoscopy that might impact these individuals' lives, but also referring these people for genetic counseling and probably for genetic testing would be of benefit, and that benefit would be to prevent people who are otherwise unaware of carrying a cancer predisposing gene, so that screening can happen at a younger age so that cancer never happens. And these are some nice references if you all want to take an extra read.
Does everything you said that applies to diagnosis of cancer apply to the diagnosis of adenomatous polyps? In other words, should you be taking a polyp history? You said we should, but recommending screening if a patient has polyps, it's still 10 years before, I presume?
I see. So I guess we're probably talking about the lag time here of recommending 10 years of anticipation for the relatives of people with findings at colonoscopy. So for cancer, there's certainly that 10-year pre or age 40, whichever is younger, but that's not necessarily the case for polyps. If all you know is that there's a family history of polyps, generally the relatives should be screened at about the same age that the polyps have occurred, unless you have some confirmation that it was a high-risk polyp, which patients will be very rare to tell you. So if you find out that if somebody had a first-degree relative with a lesion that had high-grade dysplasia, then that would be one reason to also have some anticipation to the years of screening. That's kind of a soft recommendation that's in the U.S. Multi-Society Task Force guidelines. So generally, if somebody tells you they have polyps, it's generally the same age that the polyp was identified in a family member.
All
Is
right,
that clear, or was that?
Pretty close.
Okay.
There was a question regarding the vitamin E, and why can't vitamin E be used in diabetics with biopsy-proven NASH? And I guess I'll leave that to Paul to explain. The toxicity of vitamin E in that. Specifically, what is the vitamin E toxicity?
Well, I mean, there are these concerns about increased risk of various cancers.
Okay, so more cancer risk rather than less with vitamin E. All right, Marie, you scared everyone about 6-MP. I have a patient on 6-MP, greater than 15 years, in remission. Now the patient's over 60, doing well. Should you stop it?
What disease? Crohn's? What disease?
Name a disease. Does it matter?
Okay. I guess, you know, this
NASH.
is, I mean, this is a situation where I would just have a discussion with the patient. I think most people that are doing very well are reluctant to stop therapy. I have this idea that in ulcerative colitis, when they've been in deep remission with whatever agent, I think that their microbiome is restored, and if we had better tests to sort of say, okay, look, your microbiome is now back to normal, that these are people that could probably come off and be transitioned to a mesalamine alone if they've been well for a very long time, including the well beyond well, that the biopsies look like they're completely normal. So that's why I'm saying to you, you know, in principle, it's not that I wouldn't continue it, it's just that I would ask, do we still need it? You know, forget the cancer risk, you know, do we still need it?
So I actually saw a legal case along those lines.
Okay.
It was a young guy in the Army, went to the VA hospital, new diagnosis of ulcerative colitis, started on steroids, put on mesalamine, actually got worse on mesalamine, was put on 6-MP, did well. Followed for 2 years, goes to another doctor in complete remission on the 6-MP. The doctor reviews everything, does a full colonoscopy, calprotectin, serology, everything is normal, biopsies throughout are normal. Doctor says, you're a young guy, you're 23, your risk of developing lymphoma is higher, let's just stop it. And a year later, the guy flared. Unfortunately, he went to another doctor, put him back on mesalamine, which made him so sick that he was hospitalized and ended up losing the colon. But I don't know the answer to that question.
That's a sad story.
Well, I will tell you the doctor won because it was well documented on his decision making. Okay, another one for Maria. When doing drug level monitoring for biologic agents, is there a specific level for each biologic that you are trying to target? And I'll add one other component to that. You know, is it the same for the disease? Is your target for Crohn's disease without fistula the same as your target for Crohn's with fistula?
I think one of the Achilles heels of recommending of the therapeutic drug monitoring world is exactly this, which is that it's very hard to tell you this level is exactly the level you need to achieve, and moreover, it's the added fun is that every lab reports it differently, probably has different sensitivities of their actual assays to measure it. So, you know, I'll use some trade names. You know, if you've ever ordered an infliximab Maraca level, you'll know that that level is sort of lower than if you had ordered that infliximab level at Prometheus. It doesn't mean they're wrong, it's just that you need to readjust what you're looking for. I think in general with anti-TNFs, the more inflammation that is present and the more geographical, the higher the geographical extent of the disease, the higher amount of the drug we need and the higher levels of the drug that we need in order to achieve mucosal healing. And if you carry that to the extreme, those patients that have ulcerative colitis, severe ulcerative colitis, consume the most and need the most, and those patients that have probably limited ileal disease need the least amount. Having said that, I think that I certainly think that levels in general above 10 are what I try to achieve, and I do generally order it through Prometheus. Again, I'm not trying to get you to do that. I'm just saying that we have that discussion with our patients. it's just easier for me to interpret that. That's the anti-TNFs, and I think you can apply that to both, adalimumab and infliximab. We have published from our group that patients with fistulizing disease need higher levels in order to achieve fistula closure. And then for ustekinumab, of course, we're all trying to parse through what is the right level for ustekinumab. I'll tell you that the publications to me read around greater than 4.5, a trough level of ustekinumab, checked usually before the second subcutaneous dose of the ustekinumab. The devil in the details is that probably if you order it through Prometheus, it should be, again, above 8, because their assay reports is able to detect more of the ustekinumab. For Veto, the levels seem to be higher. I usually need above 15 in order for it to be effective. Again, all of it, this is all based on my observations is, on Prometheus testing. We haven't studied it very rigorously.
Yeah, it's we discussed a little bit, it's a very challenging topic because we don't really have good evidence of how to do prospective monitoring. Adam Shefitz and Mark Osterman from Boston and Philadelphia are strong advocates. They do it, and they've shown that when they do it, they get better results. The problem is they haven't told us really how they do it, and so it's still quite challenging. As far as the levels, the AGA did put out a position paper. Although they do not yet advocate prospective monitoring, they do give target levels for all those. And if you Google any of the individual drugs, there will be target levels for them. Dan, when do you stop surveillance colonoscopy for cancer or polyps in a healthy patient? You kind of mentioned it, and there's an evolution now, right?
So you used the word surveillance there. Does that mean that person had polyps before, I guess? So there's a difference between screening and surveillance.
Okay, if they did or didn't.
So if somebody's never had polyps, so the word in that would be screening colonoscopy, then you should be individualizing your approach. And without reading a guideline and without using an exact age cutoff, if you look at somebody and talk to them and get a gestalt that you think that they've got a decent 5-10 year lifespan ahead of them, that's a person who you should consider doing colorectal cancer screening in. And once you think that somebody wouldn't be a reasonable candidate for either chemotherapy or a surgery if you found a cancer, that's probably when you should stop doing screening. It turns out also that when you look at life expectancy curves, that's where these numbers came from that are in the recommendations, and that's why they say that not everybody that's 75 to 85 should have it. It needs to be individualized because most people aren't living to be 85 years old. And that after 85 it should stop because statistically speaking, almost nobody's alive after the age of 85. So that's where those numbers came from. And then if we switch the conversation there to the word surveillance rather than screening, meaning that the person had a personal history of something, it depends what that something was. If it was a history of cancer, then we should be pretty vigilant. If it was a history of a suspicious colon lesion, then we should be a little bit more vigilant. And if it's just a couple little dinky things, probably it's worthwhile stopping if you're old otherwise.
I also ask people, when did their parents die?
Sure.
To find out whether they have, good longevity genes or not. So to make that decision, because that's also affecting us, right? Our IBD patients are also getting old and are keeping their colon. So that becomes an issue for us too, right, Dan?
Sure.
Okay, these two are questions for, it would have been for Steve, but since he is making a flight to Chicago. In post-op patients with Crohn's disease, for how long do you keep them on metronidazole if you choose to start it? I think that's a good question. I still use metronidazole. I generally aim for 8 weeks. I use it in patients for whom I'm not going to use any other therapy. I've decided they're not sick and they don't have an aggressive enough natural history to justify either continuing a biologic or starting a de novo biologic to prevent recurrence of their Crohn's disease. The tolerance of metronidazole is very much related to dose. And if you use 250 BID, most patients will not get nauseated when they're on metronidazole. So if they can tolerate it, great. I do that for 8 weeks, even though the study was done with 16 weeks. And then what is recommended for tapering corticosteroids in IBD patients? I love this question. It highlights what I try to tell fellows, that the most common things that we do all the time are the least studied. And so I generally use 40 milligrams of prednisone to start. I'll use 60 if the patient tells me, "Doc, 40 never works, only 60 works," and that's usually the UC patient, usually a big dude, okay? So I believe the patient, because that's a very specific scenario. I usually leave them on that higher dose for at least a week, and possibly 2 weeks for them to get better. Start getting worried if 2 weeks on outpatient high doses, they're not better, right? That's someone that's looking at a hospitalization. And then I taper by 5 milligrams a week until they get down to 20, and then I lower it by 2.5 milligrams a week after that. These are generally, this is how slow I go. Occasionally, patients that have been steroid dependent for a very long time, and I'm doing it one more time, I might go like down by 1 milligram below 10, because there's this mix-up of they have the disease, but they also are very steroid dependent. Just, they become not adrenally insufficient, but just they have a steroid withdrawal with a rapid taper. All righty. Can we call it quits? Or do you guys have any other questions? Any other questions? Don't be shy. No? All right. Thank you guys for coming and staying and being so interactive.